Please welcome them to the stage.
Community-based organizations are central to the global AIDS response, often displaying courage and resilience in addressing the challenges presented by the epidemic. These organizations are best placed to know the exact needs of their communities and are in the best position to know how to address those needs. They teach us how to respond to a global epidemic, one community at a time. It's a partnership initiative of the United Nations Development Programme and the entire UNAIDS family that honors and celebrates 25 community-based organizations implementing successful and sustainable programs that reduce the spread and impact of AIDS. And is presented every 2 years at the International AIDS Conference. This year, UNDP received 720 nominations from all over the world, and through an independent and civil society-led process, these 25 winners were selected to represent outstanding leadership in the following categories. Ensure that people living with HIV receive treatment. Support HIV prevention, treatment and care programs for people who use drugs. Remove punitive policies and laws, stigma and discrimination that block effective AIDS responses and marginalize key populations. Stop violence against women and girls and reduce gender inequality. Enhance social support for those affected by HIV, including orphans and vulnerable children. And now, let's welcome the 25 winners of the 2010 Red Ribbon Award. The Albanian Association of People Living with HIV provides treatment, care, and support for people living with HIV, focusing specifically on children. Through lobbying and advocacy, the organization has created a national human rights framework that now allows children living with HIV to go to school. Asociación Comité contra el SIDA Cabañas, COCOSI, in El Salvador, is a leader in fighting for the rights for women living with HIV. COCOSI works to provide services and educate the community on reproductive health and rights and violence against women and girls. Thank you. Asociación de Mujeres Meretrices de la Argentina, AMAR, Argentina, is a network of 15,000 sex workers which has successfully advocated for the adoption of new municipal codes and police orders that now protect and promote the rights of sex workers in the country. Asociación Pénitentiaire Africaine, Burkina Faso, advocates for the rights of prisoners by educating prison staff, providing legal assistance to inmates, and offering support services for vulnerable populations in prisons. The Center for Domestic Violence Prevention in Uganda focuses on the rights of women and girls and works to prevent domestic violence and HIV. Using workshops and media campaigns, they challenge gender norms and unequal gender relations. Their advocacy was instrumental in passing the new domestic violence bill in the country. Chrysalid, Mauritius, operates a center for women living with HIV and women who use drugs and their children. Chrysalid not only supports and educates women, but also offers programs that empowers women to become community leaders themselves. Colectivo Sergei de Aguascalientes, Mexico, works with men who have sex with men and transgender groups to expose human rights violation towards sexual minorities and marginalized groups. They run a weekly radio program and host a community center that is a safe space for young gay men to interact and receive medical and other support. Elan Damour, Ivory Coast, works in hospitals and other healthcare facilities, training staff to reduce stigma and discrimination in the health sector and eliminate barriers to treatment access. They also provide inside education, treatment, and counseling services. Thank you. The International Treatment Preparedness Coalition, Russia, mobilizes and trains people living with HIV to advocate for their inclusion in local, regional, and international decision-making mechanisms, and facilitates important information exchange, distributing treatment information through its web and media campaign in the whole of Eastern Europe. Nikat Women's Association from Ethiopia is the first community-based association in Addis Ababa, Ethiopia, that is devoted to improving the living conditions of poor women and commercial sex workers, thereby fighting poverty and protecting the right to health. Unfortunately, they're not here with us tonight, but they deserve a clap anyway. Novices AIDS Intervention and Rehabilitation Network in Thailand is an organization of Buddhist monks who have been trained as HIV peer educators, breaking the stigma associated with HIV and becoming a model for other novice monks and monastic schools in Thailand. The Penitentiary Initiative in Ukraine works in 6 prisons to provide treatment and support services for over 2,500 inmates. In particular, the organization works with prison inmates who use drugs and with men who have sex with men, setting up support groups and training prison staff. Physicians for Social Justice, Nigeria, has trained family caregivers and volunteers to conduct home visits to support people living with HIV, and in particular women, thereby challenging existing gender and cultural stereotypes. Positive Voice, Nepal, is an organization of drug users and former drug users who successfully lobbied for access to harm reduction services and antiretroviral treatment for people who use drugs in Nepal. Positive Women's Network, South Africa, created a safe space for women with HIV, comprehensively addressing their needs and forming a powerful group that educates the wider community about HIV and AIDS. Pride Community Health Organization in Zambia operates a safe haven for people living with HIV, particularly orphans, vulnerable children, youth, women, and people living with disabilities, providing them with HIV and tuberculosis care and support through home care-based visits. Productive Organization for Women in Action, PAWA, Belize, uses a mobile information booth featuring live music and dancing to attract a wide range of community members and educate them about HIV, gender-based violence, condom use, and HIV testing and referral services. Skin Plus, Tajikistan, provides innovative and peer-based services to drug users and people living with HIV in the country. Spin Plus's members were the first to publicly announce their HIV-positive status and to lobby to make available antiretroviral treatment to people who use drugs. The Substance Abuse and Research Center, SARC Amman, Palestine, is the first organization in Gaza to tackle issues of drug use and HIV, including stigma and discrimination. Facilitated by a team of former drug users and current drug users, they tackled stigma and discrimination, and they've built a center for building awareness among people who inject drugs, high school and university students, and they provide services in refugee camps in the Gaza Strip. Svitanok Club, Ukraine, has created and is managed by people living with HIV and people who use drugs. They provide comprehensive support services to a broad range of vulnerable groups, including women, men who have sex with men, prisoners, drug users, and sex workers. Zvitanok has become a catalyst in the creation of other organizations serving these populations in the country. The Initiative for Equal Rights, Nigeria, works to break the silence around issues of sexual minorities in the country. They have formed partnerships with human rights lawyers to increase legal advocacy and form partnerships with civil society and the government to increase HIV programming for men with sex with men. The Youth Volunteer Group, Thailand, works with some of the most marginalized children, educating them about HIV and reducing stigma and the barrier to care. Responding to the needs of children and young people living with HIV, they build their self-esteem and empower them to communicate their needs. Timur Islamov Charitable Foundation, Russia, has built strong relationships with local authorities and public health centers, and through these relationships has become a primary driver of advancing HIV testing, referrals, and support programs for drug users in the country. And finally, Widows, Orphans, and People Living with HIV/AIDS in Sudan is a community-based organization of people living with HIV that works to increase access to antiretroviral treatment by forming partnerships with hospitals, facilitating referrals for treatment, and developing a home-based care system in the region. Thank you so much, and let's celebrate the 25 Red Ribbon Award winners for this year.
We welcome again to the stage the Schönbrunn Palace Orchestra.
Less than a decade ago, the picture of health for the world's poorest was bleak. HIV/AIDS, tuberculosis, and malaria were sweeping across the globe. Devastating families, killing millions, and shattering hope. Sick mothers could not care for their families. Workers in poor health caused businesses to fail. Entire nations were being brought to their knees. The UN Secretary General called on world leaders to defend health as a human right with a bold historic experiment. The Global Fund to fight AIDS, tuberculosis, and malaria. Between 2002 and 2010, the Global Fund has committed over $19 billion in 144 countries. The fund empowers countries to develop and manage their own plans to tackle these epidemics. Diverse partnerships bring all stakeholders into the fight. Local resources are marshaled to increase access to health care in every community. In Kanzi, Rwanda, a mother and son no longer have to travel a day or more for routine medical care. A neighbor, Febroni Kankira, has become a community health worker through a program funded by the Global Fund. In facilities like these, doctors and nurses finally have the drugs and tools they need to save lives. In just a few years, dramatic improvements have begun in the fight against the world's 3 major killer diseases. 7 million people have been treated for active tuberculosis, and bed nets protect hundreds of millions of African mothers and children from malaria. 2.8 million people have received antiretroviral treatment for HIV, 2.1 million of them in Africa. And thanks to programs which prevent mother-to-child transmission of HIV, hundreds of thousands of children have been born free of the HIV virus. In Indonesia, Evi Noviandari relies on one such program to protect the health of her unborn baby.
Terima kasih banget sih ya buat Global Fund.
Since my husband died after getting HIV, my hope is very simple: to see my children happy and free from disease. I am so grateful to the Global Fund for making this program possible.
Paid for by the Global Fund, the Kabutare District Hospital in Rwanda has a pleasant, airy facility for the treatment of patients with multi-drug-resistant tuberculosis. There, Helene Uwinana, a former nurse, looks forward to returning to her work.
All the while on my way here, I had no hope I would survive. But once you're at this place, the hope comes back. And now I look forward to being discharged and going back to a normal life.
In the hospital's pediatric ward, these children would almost certainly have died from severe malaria. With treatment made available by the Global Fund, they will soon be laughing, playing, and returning to school. In large parts of the developing world, the tide is definitely turning, especially for women and children. 1/3 of Global Fund money goes into training, to building and equipping health centers, and to strengthen capacity to procure drugs and equipment. Broad, powerful, and deep, these successes are beginning to lift the burden on nations' health systems. and rippling outward, creating impact far beyond treating the 3 diseases. The Global Fund encourages governments and communities, civil society, and the private sector to join forces and coordinate their efforts.
In this country, we are very well organized in order to look at the level of implementation through field visits, through regular meetings, and interaction with stakeholders.
Thanks to the Ethiopian Interfaith Forum for Development, Dialogue and Action, supported by the Global Fund, faith leaders in Ethiopia are speaking with one voice to erase the stigma of disease, which prevents people from being tested and treated.
Stigma and discrimination is very dangerous, and we are teaching the people not to ignore our people living with HIV/AIDS. We have to share love and friendship and support them.
We have joint meetings with the Ethiopian Orthodox Church and other civil society organizations. Sharing literature and experiences gives us knowledge, and we educate our followers, us in our mosques and they in their churches.
Industry leaders know that a healthier workforce means a healthier economy, and the cost of doing nothing is far too high. Global Fund-supported programs aim to increase productivity and create more robust economies. At the Dawn of Hope AIDS Recovery Center in Adama, Ethiopia, recovered patients build new clinics, make furniture, tend farms, or raise livestock. They earn a personal income and share the profits with the center.
Today, we are expanding the center, and this new facility also will employ HIV patients and generate income by providing non-HIV medical services to the community. We hope this can be a model for our country and other African countries.
Individuals, families, communities, and entire nations can now picture a better future. Stronger and more sustainable health systems, changing attitudes, healthier communities, strategic partnerships, rising economies, vast improvements in the health of women and children. Proof that investments in the Global Fund are beginning to reap huge dividends.
Improving maternal health.
Reducing the stigma of HIV/AIDS.
Bringing faith and medicine together.
Their progress is fragile and depends on our continued support. We are all connected.
Our clinic is stronger.
Our families are stronger.
We are stronger.
An investment in one life is an investment in all our lives.
We are saving lives, and this is the most important thing you have to look at.
Your investment is working.
We cannot stop now.
With your help, the world is moving closer to a new picture of health.
Меня зовут Денис. Мне 14 лет. У меня очень веселая семья. Моя старшая сестра ходит в цирковую школу. Она хочет стать гимнасткой. Моя вторая сестра мечтает стать певицей. И все время репетирует перед зеркалом. Мой брат сейчас отдыхает на море. Он красиво рисует и любит играть в футбол. Двое из нас ВИЧ-инфицированы. Но я не скажу, кто именно, потому что это не имеет никакого значения.
HIV is spreading faster in Eastern Europe and Central Asia than anywhere else in the world. Amongst those most at risk of infection are children and young people. They are vulnerable to drug abuse and sexual exploitation. It doesn't have to be this way. By providing the correct information, support, and services, we can help them to protect themselves and stop the spread of the virus. To be successful, HIV prevention services must involve adolescents and young people, especially those most at risk of infection and those already living with HIV. Every young person has the right to be informed about AIDS, to protect themselves, and the right to be a champion. Help us to build a generation of champions, free of HIV and free of AIDS.
It was dark when I found you. I'll build you a house in the oak tree outside, and you can come back whenever you'd like. Don't be frightened, I'll set you up right, 'cause everyone needs somebody sometime. I'll leave the light on so you know I'm at home, and you can come in. You won't be alone. Don't be scared of the night, 'cause I'll fix you up right. 'Cause everyone needs somebody sometime. Sometime.
For 40 cents, I got an egg.
I got gum. I got bubbles.
I got a hairnet.
A kazoo.
A candy necklace.
An orange. A Band-Aid. For 40 cents, I got one of these.
I got a really great hat. Fabric softener.
I got half a song.
A stamp.
A ponytail.
Helium. Some bling. Some fries.
Balloon dog.
This much of a Shirley Temple. This much eyeshadow.
Extra mayonnaise.
Earplugs.
I got a mustache. 40 cents buys you this much of a manicure.
An apple.
Sprinkles.
15 minutes of parking and a ticket.
Lipstick. 2 pills a day is what it takes to stay alive if you're HIV positive. Those pills cost about 40 cents a day.
Lunch bag.
Ki-moon video.
No.
Yes, exactly.
No, what don't they?
Nothing, just the Ban Ki-moon video.
What are the sponsors?
Yeah, no, just go ahead with the Ban Ki-moon video.
Skip it. Just say when he cues you, just say the Secretary General part. Forget about the ladies.
Okay, can we go? Okay, the voice of God, go.
Ladies and gentlemen, attention. Please take your seats for special message. The United Nations Secretary General, Ban Ki-moon.
This small pack makes sure.
Ladies and gentlemen, I send my very best wishes to the International AIDS Conference. Let me pay tribute in particular to those among you who are living with HIV. Your courage has given strength to people around the world. You have helped people suffering as a result of stigma and discrimination to emerge from the shadows and to seek not only treatment, but their fundamental human rights. We have made significant progress in the global response. New infections have declined. Access to treatment has expanded. Decades-old travel restrictions are being lifted, but too many obstacles remain. Some governments are cutting back on their response to AIDS. This should be a cause for great concern to us all. We must ensure that our recent gains are not reversed. We must raise additional resources for other areas that have been neglected for far too long. Maternal health in particular. We must also recognize the intrinsic links between AIDS and our work to achieve the Millennium Development Goals, especially women's and children's health. The MDGs are indivisible and should never be pitted against each other. So let us say again, no new HIV infections, no more discriminations, no more AIDS-related death, health and development for all. And as this conference proclaims, rights here, right now. This is a bold vision. To realize it, universal access must remain our beacon. Access to life-saving drugs, access to HIV prevention, treatment, care, and support. Next year marks a milestone. 10 years since the UN Declaration of Commitment, 5 years since our political declaration. It will also be a year in which the General Assembly convenes for a crucially important meeting aimed at strengthening the global response further still. I look forward to your contributions. I look forward to working with you to conquer this disease once and for all. Thank you.
Ladies and gentlemen, the conference chair and the local co-chair, Drs. Julio Montana and Brigitte Schmidt.
You ready?
Yeah.
Before we start, let's make one thing clear for everybody. There should be no retreat. Fund AIDS, we fully agree.
We agree. So you are naming the fund?
Yeah, you name them all.
I read them, okay.
Ladies and gentlemen, distinguished guests, a very warm welcome to Vienna. Dobro pozdravovat Wien. Herzlich willkommen in Wien. I would like to thank the Vienna city government and the Federal Ministry of Health. Thank you as well, AIDS-Hilfe Wien, and many other local organizations for their contributions and support during the organization of AIDS 2010. Thank you very much to all sponsors and donors, for example, Abbott Virology, Boehringer Ingelheim, Bristol Myers Squibb, Gilead, MSD, Tibotec, ViiV Healthcare. Finally, I would like to thank you, Julio, as well as the International AIDS Society and its international partners for choosing Vienna to host AIDS 2010. Vienna was chosen to host the conference because our city is a crossroads between East and West. Eastern Europe and Central Asia is the region with the fastest growing epidemic worldwide. And just a few hundred kilometers away, east of Austria, a very different epidemic from what you will find here, you find there. In contrast to universal access in Austria, in the neighboring region of Eastern Europe and Central Asia, just 23% of people who are in need have access to antiretroviral treatment. And globally, in 2008, more than 10 million people living with HIV were still in need of treatment, and a figure that has grown substantially since then. In Austria and other parts of the world, HIV is a chronic disease. But in many others, people are turned away from clinic and denied life-saving treatment due to shortages. In those same areas, including the most heavily affected region of Southern Africa, funding shortfalls will result in rationed care and the agonizing choice of who is allowed to live and who will die. We must not let that happen. AIDS was never just about science. It has always been about social justice as well. And that is part why the AIDS 2010 theme of Rights Here, Right Now emphasizes the role of human rights in the scale-up of HIV programs, including the right to live a life free of stigma and discrimination. Rights Here, Right Now also emphasizes the right to health care, including access to all scientifically proven HIV prevention interventions, such as opioid substitution therapy and needle and syringe programs. To this end, I urge all of you to add your voice to the growing call for the reform of illicit drug policies by signing the Vienna Declaration. Treatment, not prosecution, is demanded. Over the past 7 years in particular, we have demonstrated that effective treatment can be brought to scale, and in doing so, we have learned that HIV treatment significantly reduces the risk of transmission. With regard to prevention, we know that a combination of behavioral and biomedical strategies is most effective, and that these strategies must be reinforced with structural interventions that create an enabling legal, social, and political environment. Repealing laws that criminalize homosexuality and addiction, and empowering and educating especially young women and girls are important examples. recent progress in scaling up HIV prevention, treatment, care and support has been remarkable. In the past 5 years alone, the availability of antiretroviral treatment in low and middle income countries has increased tenfold to 5 million people. Just 10 years after Durban, we have shown the skeptics that universal access is achievable. That is the goal we can and we must reach. AIDS 2010 participants have come to Vienna from more than 185 countries, something that would not have been possible 100 years ago. As our world becomes smaller, let us try to remember that the goal of universal access to treatment, prevention, care and support, as well as global health, is ultimately about communities, about families and about individuals, each with his or her own story. It's the mother who must leave her newborn in hospital because she has no capacity to care for her child due to the lack of social support. It's the person who injects drugs and is harassed or even beaten while picking up clean needles and syringes to protect himself and his partner from infection. And tragically, it's the child suffering from AIDS because his parents deny the existence of HIV. In our shrinking world, the goal of universal access and global health can no longer be viewed as a story about others. These are our stories. Universal access is our responsibility, and holding ourselves and our political leaders accountable is our continued challenge. Let us meet this challenge with tenacity and fervor in the days and months ahead. Thank you.
We also agree sex work is work and it should be decriminalized. Thank you, Brigitte, for your kind remarks and looking after the formalities. I would like to briefly share with you some of my most pressing concerns as we gather in Vienna at this very important 18th International AIDS Conference. Dear friends, we find the global AIDS response at a crossroads. In 2005, Gleneagles and the G8 set 2010 targets for universal access. These represented a bold and visionary objective. In short order, it led to the establishment of one of the most successful ever multilateral and bilateral efforts, including the Global Fund, PEPFAR, and other such initiatives. We went from almost nobody on HEART in 2005 to 5 million plus today. This unprecedented rollout success proved many skeptics wrong. Having said that, I cannot hide my profound disappointment and deep frustration with the recently concluded G8 and G20 meetings in anywhere else but Canada. By failing to take full responsibility for the Universal Access Pledge, and more importantly, for failing to articulate the next steps to meet not just the 6 MDG, but also all of them, because without universal access, there shall be no MDGs by 2015. We have heard excuses related to the fiscal crisis, but we were falling behind way before the fiscal crisis ever became a problem. If lagging countries like my own Canada would have matched the American contribution to the fight in HIV on a GDP basis, we would be seeing a vastly different picture today. Let me remind you Over the last year, the same leaders had absolutely no problem finding money on a moment's notice to bail out their corporate friends, the greedy Wall Street bankers, and yet when it comes to global health, the purse is always empty. A full 110 billion euro appeared from nowhere when the Greek economy faltered earlier this year. But when it comes to universal access, we simply are choosing to ignore it. That is not acceptable. Quite simply, it is a matter of priorities. The G8's priorities have to change. Our number one goal here today and for the rest of the week is to send a very clear, evidence-based message to the G8 why they should do so and why they should do so now. So, what is the evidence? As I recently learned from an old Chinese proverb, I would like to tell you today, don't let those that say that it cannot be or will not be done stop those of us that are doing it. And we have no intention to stop. We will continue doing it. Over the last 5 years, the science has improved and enhanced dramatically, supporting the value, the multiple layered value of the Universal Access Pledge. Recently, the World Health Organization has put forward new guidelines calling for better heart regimens and earlier initiation of therapy at a higher CD4 count of 350. Some argue that that was a problem. We argue that is part of the solution, and we congratulate the WHO for that. In addition, in the last several years, several groups, including our own, have generated a compelling body of evidence demonstrating that HEART is not only highly effective at preventing HIV-related morbidity and mortality, but it also dramatically decreases HIV transmission from all routes. This has now been widely accepted as the way to eliminate vertical transmission of HIV, and WHO and UNAIDS have called for the global elimination of vertical transmission as a result, and this should be done urgently. More recently, a study funded by the Gates Foundation in 7 African countries, published in The Lancet last month, showed a greater than 90% reduction on HIV transmission when the infected index member of a serodiscontact couple was treated with antiretroviral therapy. Work from Vancouver has added to this when we showed in a recent number of The Lancet earlier today that by treating more, we prevent more. In fact, even among IDUs, we saw a 50% reduction, 50% of HIV new diagnosis as a result of the increased coverage with HEART. As my friend, past president of the IAS, Pedro Kahn, said at the last plenary on antiretroviral therapy in Cape Town, it is no more treatment and prevention, treatment is prevention. This new understanding represents a true game changer. This has been now acknowledged by multiple parties. It's time to move on it, and it's time to move it now. I was actually pleased, very pleased, when France's First Lady, Ms. Carla Bruni Sarkozy, said, we have a historic opportunity. In a few years, we can control AIDS, we can eradicate it from the surface of the planet. She added, in the Daily Liberation, when writing these notes, she said, treating everyone means halting the transmission of the virus. In other words, stopping the epidemic. She said, solutions can be imagined for today and tomorrow, but she cautioned, we must act very quickly. and she requested that an international tax be considered to raise the much-needed financial support. We're full behind those comments, and I remind you, the next G8 will be on Sarkozy's land, and we expect he will follow his wise words. Consensus has arrived. Treatment and prevention are one thing, and they are the way forward. Universal access is the way forward. As it was announced earlier today by my good friend and colleague Michel Sidibe, the Executive Director of UNAIDS, Treatment 2.0 represents the single most important thing coming out of this meeting. It is the most effective way forward to deliver on the Universal Access Pledge. Let's rally behind Michel and be sure that Treatment 2.0 is indeed a reality. The theme of AIDS 2010, Right Here, Right Now, was chosen to emphasize the critical and fundamental connection between human rights and HIV. There can be no end to the pandemic if we don't secure full protection of human rights for those that are vulnerable or living with HIV. Stigma and discrimination, persecution, prosecution, and criminalization in the various forms concerning infected, affected, and at-risk populations are major obstacles to controlling HIV in the world today as we speak. These are huge barriers to HIV testing, care, and support, and dramatically increase the risk of HIV transmission. As we move to enhance efficiencies and get better bang for our buck, we must recognize that full protection of human rights represents a fundamental first step to achieve this goal. We waste too much money looking for people that the police is chasing on the other hand. Stigma and discrimination result in misguided policies and misallocated resources, as many governments are averse to implementing scientifically sound programs for key at-risk groups, including people who use drugs, sex trade workers, and men who have sex with men. Gender discrimination contributes to the heightened vulnerability of HIV among women and girls. For all of these reasons, I urge you to join former presidents, Nobel laureates, and the scientific community, as well as myself, and the full 10,003 people that have signed already the Vienna Declaration, which hopefully will motivate people to move away from the war on drugs into an evidence-based approach to drug policy. Today, with the start of the 2010 AIDS Conference, we raise our voices louder and demand faster action from our political leaders. We can and we will overcome. Let Vienna be the beginning of a different new era. Thank you.
We now present Mr. Vladimir Zovitiak and Ms. Sasha Volgina, who will speak on human rights in Eastern Europe and Central Asia.
First of all, no retreat, fund AIDS. We are dying less, but we are dying faster.
Нас умирает меньше, но мы умираем быстрее. Мы — это 300 миллионов человек. Мы — это люди, которые живут в странах Восточной Европы и Центральной Азии. И у нас самые быстрые темпы развития ВИЧ-инфекции в мире.
300 million people live in our region. The region of Eastern Europe and Central Asia includes 18 countries, and we have the world's fastest rates of epidemic growth.
Теперь 100 тысяч людей в нашем регионе получают лечение. Но эпидемия растет, и еще 300 тысяч нуждаются в лечении сейчас.
Now, 100,000 people receive IV treatment in our region, but our epidemic is growing faster. And still, 300,000 people are in need of treatment now.
Все мы ВИЧ-позитивные, но мы очень разные. В одном регионе мы перелетаем от католических соборов Литвы к мечетям Узбекистана, от горы Арарат к холодным волнам Балтии в Петербурге.
We are very different. Our region is so big that when we visit our colleagues, we fly from Catholic Cathedral of Lithuania to the Islamic mosque in Uzbekistan, from highest mountains of Ararat to the cold, grey waters of Baltic in St. Petersburg.
Мы живем в разных странах, но у нас общая история, общие трагедии и общие достижения. Первый полет человека в космос Юрий Гагарин, периодическая система химических элементов Дмитрия Менделеева, учение о защитных силах организма Ильи Мечникова.
We are 18 different countries, but we are united by our history and we are united by joint tragedies, wars and successes. It's a first flight to space by Yuri Gagarin. It's periodic table of chemical elements by Dmitry Mendeleev. It's first research of immune system by Илья Мечников.
Наши страны дали миру Льва Толстого и Федора Достоевского, Адама Мицкевича и Назыма Хикмета, Андрея Шевченко и Костю Дзю, Сергея Бубка и Андрея Аршавина.
Our region gave the world Lev Tolstoy and Fyodor Dostoevsky, Nazim Hikmet and Adam Mickiewicz, Andrei Shevchenko and Kostya Дзю, Сергей Бубка and Андрей Аршавин.
Миграция, бегство от катастроф 20 века породили любовь и сострадание многих людей, выходцев из нашего региона. Мишеля Казачкина, сделавшего для нас больше, чем все политики нашего региона. Дэвида Бара, хранителя идеи КТАПа, который сегодня вместе с нами призывает правительство выполнить взятые на себя обязательства. Джея Добкина, привозившего нам лекарства и лечившего нас, когда мы умирали.
Migration, escape from tragedies of 20th century, inspired the sympathy and personal commitment of many people whose roots are in our region. Michel Kazachkin, born in Russian family, who has done more for us than any of our own politicians. David Barr, the living legend of Akhtab, who today with us is calling governments to keep their promises. Jay Dobkin, who was our doctor, who personally brought medicines to us when we were dying.
Мы строим независимость наших стран, учим детей говорить на родном языке, учим любить культуру родной страны, хотя все мы имеем общее прошлое. Мы выросли в одной стране, нас объединяет ее распад, войны и кризис.
We are building independent countries. We are teaching our children to speak in our national languages. We are teaching them to love the culture of their motherland. Although we have common history, our generation grew up in one country. Our generation suffered most from its breakup, civil wars and crises.
А также нас объединяют самые высокие темпы роста эпидемии ВИЧ в мире.
And also, we are united by the world's fastest rates of HIV epidemic.
500 наших близких, друзей, детей инфицируются ВИЧ каждый день в странах нашего региона.
Every day, 500 of our friends, loved ones, our children are infected with HIV in our region.
Нас умирает меньше, но мы умираем быстрее. Каждый второй ВИЧ-позитивный человек умирает от туберкулеза. И гепатит С угрожает жизням миллионов ВИЧ-позитивных людей. Мы умираем, потому что нет лечения наркозависимости. Мы умираем из-за двойной дискриминации, смертного приговора для ВИЧ-позитивных потребителей наркотиков, женщин секс-бизнеса, мужчин, имеющих секс с мужчиной.
We are dying less, but we are dying faster. Each second HIV person in our region is dying from tuberculosis. Hepatitis C is threatening the lives of millions of HIV-positive people. We are dying because we don't have access to drug dependence treatment. We are dying because of double stigma and discrimination for HIV-positive drug users, for sex workers, for men having sex with men, for lots of us.
Наши права нарушаются, и мы умираем из-за нехватки антиретровирусных препаратов, как это происходит в России и в Украине, из-за закрытия сайтов заместительной терапии, как это произошло в Узбекистане, из-за репрессивной наркополитики, при которой каждый четвертый ВИЧ-позитивный в нашем регионе находится в тюрьме, из-за коррупции в системе государственных закупок.
Our rights are violated, and we are dying from IRV shortages like it happens in Russia, from the closing of substitutional treatment sites like it happened in Uzbekistan. We are dying from repressive drug policies when every fourth person living with HIV in our region is in prison. We are dying from the corruption in governmental procurement of IRVs, when mothers have to give their pills to their children.
Поэтому мы, люди, живущие с ВИЧ, призываем лидеров наших стран взять противодействие эпидемии ВИЧ под свой личный контроль, признав эпидемию ВИЧ угрозой национальной безопасности.
That's why we, people living with HIV, we call upon leaders of our countries to accept the HIV epidemic under their personal control. We call upon presidents and prime ministers to recognize HIV as a threat to national security.
Именно сейчас мы призываем мировое сообщество поддержать нашу работу устойчивым финансированием, которое спасет жизни миллионов людей и наш регион.
And now we call upon global community to support us with sustainable funding to save lives of million people in our region.
И тогда мы перестанем умирать, и тогда мы будем жить.
And that will be time when we'll stop dying. That will be time for us to live.
И наша задача людей, живущих с ВИЧ, определить новое будущее, в котором не будет места коррупции, стигме и дискриминации, двойной стигме, не будет всего того, что мешает нам жить.
Our task, the task of people living with HIV, is to build a future where it will be no place for corruption, for stigma, for discrimination, for enslavement of one human being by the other.
И как сказал ВИЧ-позитивный активист Виттор Руссо, сперва мы покончим с этим заболеванием, чтобы выжить. А выжить нам нужно для того, чтобы покончить с этой системой, чтобы это никогда не повторилось вновь. И тогда мы будем жить.
And as HIV activist Vito Russo said, and then after we kick the shit out of this disease, and we are going to be alive. We are going to be alive to kick the shit out of the system so that this never happens again. Сейчас. And that's then when we will still stay alive. Thank you.
Dr. Yves Souterrain will now deliver the first plenary presentation on the state of the epidemic.
Good evening, dear friends. I want first to thank the organizer for inviting me to be here today. It's a great privilege for me to be present on the global AIDS epidemic and on the links between human rights and the response to AIDS. This quote for Amartya Sen, winner of the Nobel Prize in Economics, helped to contextualize the presentation. To understand the problem with clarity is already halfway toward solving it. Ignorance of the effectiveness of societal interventions contributes greatly to resignation, fatalism, and callousness. This is true of the global epidemic of AIDS today, as it has been of the other major human disaster in the past. The AIDS epidemic is a story of a global public health crisis where the ability to know your epidemic and to use that knowledge to inform the AIDS response is strongly dependent on protecting human rights. First, I will review progress made in controlling the epidemic due to increased global financing and action. However, doing more of the same will not take the global AIDS response to the next level. Over the last 15 years, our knowledge of HIV has improved dramatically, but progress on human rights has not. I hope to show that without urgent action on human rights, we will not achieve the results necessary to halt and reverse the epidemic. This slide summarizes the evolution of the epidemic over the last years. At the end of 2008, as you can see looking at the gray bars on the slides, 33.4 million people were living with HIV, including 2.1 million children under 15. These represent a global prevalence in the adult population of 0.8%. This figure peaked in the early 2000s, but the global number of people living with HIV continues to increase due to global population growth, high incidence, and reduced mortality among people living with HIV. The annual number of new HIV infections, which is in red on the slide, peaked in 1996 and gradually declined since then. In 2008, there were 2.7 million new infections, including 430,000 children, 1/4 less than at the peak. In 2008, 2 million people died of HIV/AIDS, as you can see following the yellow line on the graph, including 280,000 children. Due to the scale-up of antiretroviral therapy, mortality has decreased since 2004, when the annual number of AIDS-related deaths peaked at 2.2 million. HIV continued to be the #1 killer globally for women of reproductive age and one of the largest single causes of mortality worldwide. This is a global snapshot of the epidemic. Despite reduction in new infections, every day an estimated 7,400 people are infected with HIV, including 1,200 children. 5,000 people die of HIV/AIDS, but approximately 3,000 more are placed on antiretroviral therapy. The epidemic continues to outpace efforts to contain it. Low and middle-income countries, especially those in sub-Saharan Africa, are disproportionately affected by the burden of the epidemic. Compared with 2001, when the UNGAS Declaration was launched, the decrease of new infections is, of course, positive news, but it is far from what is needed to consider the epidemic under control. The HIV epidemic remains a major obstacle to the achievement of all health-related Millennium Development Goals, including MDG 4 on child mortality and MDG 5 on maternal mortality, and it is also a major obstacle to the control of TB epidemic. Increase in AIDS financing has allowed the rapid scale-up of HIV interventions. Yet assessing the impact of prevention intervention is complex. Part of the decreases in incidence can be attributed to the natural evolution of the epidemic, the fact that individuals with highest risk behaviors are affected rapidly. Incidence will naturally fall after the epidemic has moved through this population. However, recent evidence confirms that prevention impacts at the population level. A systematic analysis of countries with generalized epidemic will be presented during the conference. It demonstrates that both HIV prevalence among young people and high-risk sexual behaviors have declined in most countries between 2000 and 2008, including 10 countries reporting prevalence declines of more than 25%. And the recent modeling studies has also estimated that in an area of Zimbabwe, prevention interventions have been responsible for averting between 460 and 860,000 infections from 1999 to 2004 due to reductions in risk behavior. UNAIDS recently estimated the impact of antiretrovirals to prevent vertical transmission on the number of infections averted in infants. This slide estimates that in total, 200,000 HIV infections among children were averted globally in the past 12 years due to these interventions. As access to antiretroviral prophylaxis for pregnant and breastfeeding women expands, that figure will continue to increase. More than 5 million people are currently on antiretroviral therapy in low and middle-income countries. We have started getting good estimates in different countries on the impact of art on reducing deaths at a population level. The table on this slide is based on repeated population survey in South Africa. It shows that thanks to art, approximately 440,000 South Africans remain alive. Additional HIV prevalence is good news when it reflects longer lives for people with HIV. This slide refers to a hot topic of this conference that Julio has already addressed, the impact of art in reducing HIV incidence. It brings to mind a number of recent studies, including a trial among serodiscordant couples in Africa and recent ecological studies in San Francisco and Vancouver. Additional research is needed to confirm the long-term impact of art on population-level incidence, but evidence to date suggests expanded access to art would have a significant impact on the epidemic and is a powerful new argument to increase AIDS investments. The theme of the conference, Rights Here, Right Now, speaks to both the necessity and urgency for human rights to play a central role in the response to the epidemic. As we have just seen, we have made encouraging progress in different domains. But we cannot ignore that much of our accomplishments have been reached working with populations that are relatively easy to access with HIV services. Reducing new infections has proven to be more difficult to achieve among vulnerable and most at-risk populations, who are often among the most marginalized, stigmatized, and discriminated against. I will turn now to show how the lack of human rights protections are compromising the response and limiting progress to halt and reverse the epidemic. The framework developed by the WHO Commission on Social Determinants of Health is helpful in outlining the factors affecting health status and access to health services. It helps to locate human rights violations or protections as part of the social determinant of health. And two determinants in this framework are particularly important in the context of the AIDS epidemic. First, governance and policy that violate or protect human rights of key population. For example, laws criminalizing sex work which contribute to vulnerability of sex workers to HIV infection, to violence, and often reduced access to health services. Second, social and cultural norms and values such as gender inequity, which makes many women and girls more vulnerable to HIV infections. HIV and human rights are intimately linked in four ways. First, human rights violations are a barrier to knowing your epidemic. Second, unethical HIV surveillance exacerbates human rights abuses. Third, human rights abuses contribute to HIV transmission and the expansion of the epidemic. Fourth, failing to act on the epidemiological evidence, or worse, using the EpiData as a rationale for criminalizing behaviors worsen human rights challenges faced by vulnerable and most at-risk populations. This map depicts results from a recent study of the quality of national HIV surveillance systems. Granted, they have improved considerably since the start of the epidemic. However, as we can see in yellow and red on the map, many countries, especially those with low-level epidemics and those with epidemics concentrated among most at-risk populations, have weak surveillance systems. Most concerning, even in countries with strong systems marked in green on the map, epidemiological information on most at-risk population is often scarce or of poor quality. This problem is further compounded by the absence of strong health information and vital registration systems. The reality is that human rights abuses and violations continue to undermine the collection, analysis, and use of good epidemiological data. It is hard to conduct surveillance among population when their behaviors are criminalized or denied by public officials, and when participation in research could endanger their lives. Unethical surveillance can further exacerbate stigma and discrimination faced by individuals. Moreover, unless surveillance activity can ensure the privacy and confidentiality of health information, it is likely to severely discourage personal disclosure about risks and behaviors, thus compromising the quality of the data obtained. Addressing this issue requires close collaboration with communities in the collection and analysis of data. At last, as stressed in the quote on these slides, critical also is a moral requirement to ensure responsiveness to epidemiological evidence. There are still too many discrepancies between epi-evidence and programmatic focus. Convincing evidence on links between human rights, the HIV epidemic, and the response to AIDS is available. There are many examples from different populations, including women, children, sex workers, prisoners, and transgender communities, all of which face unique vulnerabilities that increase the risk of HIV infections. Time permits me to focus on only a few, so I will look at migrants, men who have sex with men, and people who inject drugs. Epidemics among migrants provide a convincing example of the complex link between human rights, epidemiology, and the response. Data presented here demonstrate the scope of the epidemic among migrant population in France, my country, if you have not understood, Spain, and the Netherlands. In these three countries, between 1/3 and 3/4 of the epidemic is among people from other countries of origin, mostly from sub-Saharan Africa for France and the Netherlands, and from Latin America for Spain. The recent report from the European CDC outlined tensions between immigration and security policies on one hand and health policies on the other. These tensions undermine access to HIV prevention, testing and counseling, treatment and care, especially for undocumented migrants. Migration policies focus on protecting borders and deporting illegal immigrants. In the current context of economic crisis, there is a risk that collecting and disseminating such information on the epidemic among migrants could increase stigma and discrimination faced by these communities. However, ignoring the epidemiological evidence among this population also prevents opportunities to develop urgently needed health interventions. The slide illustrates results of the UNAIDS mode of transmission model developed in sub-Saharan Africa in 2008 and 2009. Although the majority of infections are due to single or multiple partners heterosexual transmission, most at-risk populations contribute almost 23% of new infections in West Africa. MSM represents around 10% of new infections in Côte d'Ivoire, Ghana, Kenya, Nigeria, and Senegal. IDUs represent around the same proportion in Nigeria. After many years of steady declines, the past several years have seen gradual increases in new infections among MSM in many high-income countries. But the situation for MSM in low and middle-income countries is even more concerning, as shown in a last week paper by Bayer based on 50 countries. AP reports indicate HIV prevalence even in settings where rates of HIV infection in other populations is decreasing. Globally, the risk of HIV infection is almost 20 times greater for MSM populations compared to general population. The Barral paper on the slide found strikingly high level of prevalence among MSM in Botswana, Malawi, and Namibia, up to 36% of all HIV prevalence among MSM over 30 years of age. The same study provides evidence of the high prevalence of human rights abuses, with more than 40% of MSM reporting at least one human rights abuse, such as being blackmailed or denied health services. MSM face formidable human rights challenges and some of the poorest intervention coverage of most at-risk population. Homosexuality is criminalized in 80 countries around the world, with penalties ranging from significant prisons to death sentences. Human rights abuses and intense homophobia correlate with poor access to prevention interventions and high HIV prevalence. This slide illustrates the link between criminalization of homosexuality and high HIV prevalence among MSM in different Caribbean countries. Responses to AIDS in most African countries has not adapted to evidence of significant HIV prevalence among MSM, and few programs provide HIV services to this population. In some countries, new legislation or expansion of existing anti-homosexuality laws have been proposed or implemented, including criminalization of organizations advocating for gay rights. The case of MSM highlights how laws and law enforcement, combined with social norms that include homophobia, are compromising both knowledge of the epidemic and an effective and comprehensive response. As with MSM, the response to epidemic among people who inject drugs is too frequently not aligned with the burden of the epidemic. Some of the lowest coverage of evidence-based intervention, such as opioid substitution therapy and needle and syringe exchange programs, is among countries that have significant IDU epidemics, including several countries in Eastern Europe and Central Asia. IDUs face a double legal challenge. First, laws that limit access to relevant evidence-based intervention. And second, drug control laws, part of the global war against drugs, that criminalize drug use. This law often results in police violence and in some cases in compulsory confinement in drug detention centers. Human rights abuses are commonplace. Individuals are denied access to basic health services. This slide is part of a study by Stradies that provides an innovative analysis of the potential link between an action on structural factors and the epidemic among IDUs. The study applied to Ukraine models the impact of a human rights intervention, in this case reduction in police violence against IDUs, in reducing HIV incidence. A significant proportion of IDUs report being beaten by police. This can have an indirect effect on HIV risk by discouraging IDUs away from harm reduction settings. These actions can increase the likelihood of injecting with contaminated equipment. The authors of the study made the assumption that eliminating police beatings would remove the excess in risk behavior across the population. In Ukraine, the model applied to the 3 cities with the highest HIV prevalence among IDUs in the country suggests the decrease of the incidence by as high as 19%. To end this presentation, I will focus on Ukraine's health response, for it shows both the progress that we have made and the challenge that lie ahead. The Ukrainian experience reflects how to effectively address each of the 4 links between epidemiology and human rights. Ukraine improved knowledge of its epidemic with a comprehensive surveillance plan. Involvement of the health sector, NGOs and IDU communities has been key to ensuring good epidemiological data. The country responded to the EP information by scaling up evidence-based prevention and treatment interventions for people who use drugs, including, since 2004, opioid substitution therapy. After 10 years of consistent growth, the number of officially reported new cases of HIV has been decreasing among IDUs, slowly but steadily. Even more encouraging, as shown on the slide, is that these decreases have more than doubled among IDUs with a recent history of drug injections. Collaboration among the health sector, law enforcement agencies, IDUs communities, and NGOs has been critical to success to date. However, only 35% of IDUs have access to this service, and these programs are not available in prisons. Ukraine's long-term success should build on these good initial results by strengthening human rights protections and expanding evidence-based interventions for IDU and other affected populations. Let me turn now to my conclusions. First, we have now more and better data than ever. Still, we must redouble our efforts to improve health information and vital registration system, for they remain a major bottleneck for data generation and policy development. Second, after 30 years, human rights abuses continue to blind our knowledge of the epidemic, to contribute to its expansion, and to challenge our ability to respond. Third, concerted efforts and expanded access to HIV services are having impact on the epidemic, decreasing new infection and deaths. But it is just a start, and our challenge now is to expand the response in all kinds of epidemics to reach those groups that are most marginalized, such as injecting drug users, migrants, sex workers, transgenders, young women, men who have sex with men, prisoners. Fourth, we must acknowledge that human rights violations are not the only contributor to an expanding epidemic, and then human rights protection alone will not end AIDS. But it is also true that universal access to prevention and treatment cannot be achieved without universal access to human rights. Human rights promotion is an essential component of a comprehensive public health response to AIDS, without which this crisis will not be controlled. I would like to end my presentation with the words of Jonathan Mann. Very early in the epidemic, he outlined how human rights principles should provide a foundation for an effective public health response to the AIDS epidemic. He said, "Health and human rights are 2 entirely complementary ways of speaking about and working to ameliorate human suffering in all its forms." 12 years after his tragic death, his visionary approach has proven to be essential in articulating a response to the epidemic. In 2006, at the United Nations High-Level Meeting on AIDS, heads of all member states reaffirmed that the full realization of all human rights and fundamental freedoms for all is an essential element in the global response to the HIV/AIDS epidemic. We must together ensure that this visionary commitment of our political leaders be translated from rhetoric to reality. Let me acknowledge all those who contributed to this presentation, my 4 co-authors, Rodney Court, Anish Akarishvili, Thomas Rele, Chema Calera, my colleagues from WHO and UNAIDS who have supported this development, and many other colleagues, scientific and friends who have helped me, whatever their contribution, to articulate it. I thank you very much for your attention.
Ladies and gentlemen, Mr. Alois Stuger, Austrian Minister of Health.
Sehr geehrter Herr
Federal President Fischer, dear colleagues, Your Excellencies, ladies and gentlemen. It is a great honor for me to welcome all of you today here in Vienna to this very important International AIDS Conference, following the motto of the conference being right here, right now. 30 years ago, Austria had its first cases of a disease, the likes of which no one had ever seen. Today, we know what those cases were. It was HIV and AIDS. Back then, HIV and AIDS was a deadly disease, non-treatable and non-curable. Back then, we hardly had any information on the nature of the disease, and there was no prospect whatsoever for developing an effective therapy or an effective vaccine. Under those conditions, our only option was to verify and substantiate what we already knew and pass this knowledge on to the public in campaigns that were as broad-based as possible. For us, it's been a very important endeavor to inform people about how they can keep from becoming infected. The Austrian health policy very quickly was able to drive back the transmission via blood products or hospital stays were potential sources of transmission. Austria quickly put health policies in place to alleviate these problems. Of course, another task of government policy is to protect people with HIV/AIDS from discrimination. Austria responded early on by adapting pertinent provisions of law. These new regulations set top standards for the safety of blood products and ensure free access to testing and treatment. Anyone infected with HIV or sick with AIDS can rely on the Austrian health system. Medical treatment is state-of-the-art and paid for by a public health insurance system based on solidarity. Austria always considered education and prevention efforts extremely important. The only way citizens can prevent possible infection is if they receive correct and accurate information. AIDS relief organizations do important work in this regard. For instance, the AIDS Hilfe in Austria stages workshops in schools nationwide, informing young people about the risks associated with HIV/AIDS and reducing their fear of contact with those suffering from HIV and AIDS. In addition to this educational work, Austria launched needle exchange programs for drug addicts and drastically reduced the rate of infection from dirty needles. Another very important step was the introduction of nationwide substitution programs to assist drug addicts. Much has also been done in Austria for people with HIV and AIDS. The new therapies available since 1997 sharply reduced the number of cases of individuals developing AIDS and dying from AIDS. I would like to emphasize again that in Austria, the government pays for all forms of therapy. Austrian health policy has accomplished a great deal. Medically speaking, people with HIV and AIDS are given everything of benefit to them. Considerable progress has also been made in fighting discrimination against people with HIV/AIDS. And it was the constant involvement of the NGOs that contributed to bringing about progress in this respect. However, I would also like to once again stress that we by no means can rest on our laurels. We must continue to fight discrimination against people with HIV/AIDS. It's there for sure that we still need to do a lot of work in this area. As a representative of the country hosting this conference, I hope we can share our successful experience, and I encourage all neighboring countries, to the extent they haven't done yet, to lay down a solid legal foundation for implementing a comprehensive program to fight HIV and AIDS. Thank you very much for your attention and your commitment.
Please welcome Mr. John Dalli, the European Commissioner for Health and Consumer Policy.
Ladies and gentlemen, I am extremely delighted to have the honor of participating in this important conference, which the European Commission is very pleased to support. HIV and AIDS have now been wreaking havoc on people and communities across the world for more than a quarter of a century. More than 2 million people still die of AIDS each year, and almost 3 million people become newly infected. 1% of these new infections occur in the European Union. That might sound like a relative success. However, even our relatively affluent society is suffering from an increase in infections. One of our main objectives is to strengthen cooperation between the European Union and our neighboring countries to tackle the HIV epidemic. And in a broader context, we express our disappointment at the fact that the Millennium Goal of universal access to HIV prevention, treatment and care by 2010 has not been met. We must step up efforts to fight this chronic situation. The EU member states have recently reaffirmed their determination to support the achievement of the Millennium Goal development goals. This resolve recognizes the need for all partners to demonstrate firm political commitment to implement policy changes and to take concrete action. I believe health is a universal right, and so is access to HIV treatment. Sadly, a right that is still denied to millions of people. HIV treatment is not a luxury. It is a matter of life and death. And this is why it must be and it must become universally available. This will pay dividends not just for people, but for society as a whole. The EU was among the first contributors to the Global Fund to fight AIDS, tuberculosis and malaria, to which the European Commission alone has pledged more than 1 billion euros. We sincerely hope that big donors, wealthy countries, and other organizations will continue to contribute. Contributing is not just a question of donations. It is a question of strengthening country ownership and aid effectiveness through long-term and predictable financing. We will continue to keep AIDS high on the agenda of our dialogue with partner countries and civil society. Right here, right now, the rallying call of this conference is certainly well chosen. The time has come to turn well-meaning goals into tangible successes. We need to improve access to information, to prevention, to treatment, to care, and to support. And stigmatization and discrimination must be the focus of greater attention. Some might think it is easy for a European to say this. But as we made clear in our European aid strategy, even here in Europe, we need to improve leadership and to empower civil society. We need greater efficiency of prevention and anti-discrimination measures. And finally, we need equal access to treatment and care. Let me highlight the situation in the European Union. There are major inequalities in treatment coverage across Europe, from 8 to 100% of those who need it. Costs for treatment differ enormously between EU countries, with stocks of medication sometimes running out. Between 15 to 38% of people living with HIV in the European Union do not know they have HIV, and many people do not have any access and easy access to a testing center. Some countries provide comprehensive harm reduction measures, while others do not. Ladies and gentlemen, we must put an end to this epidemic. We must stop HIV's path of destruction. Politicians, policymakers, international organizations, businesses, celebrities, health professionals, citizens, we all have a role to play to support the AIDS community and to do everything in our power to fight AIDS. And this is why we are here today. I am confident that a clear vision will emerge from this conference on how our goals and targets can be reached for the benefit of those millions of people living with HIV/AIDS. Thank you very much.
Dr. Sharon Lewin will now deliver the second plenary presentation on the state of the epidemic.
Thank you. Good evening, ladies and gentlemen. I would like to thank the conference organisers for the great honour in being invited to give this talk. But more importantly, I'd like to thank the conference organisers, the International AIDS Society, and particularly Françoise Barrot-Sinoussi for their leadership in the quest to find a cure for HIV and giving this issue such great prominence at this meeting. Universal access to antiretroviral therapy remains an undeniable human right that we must support, but ultimately we must find a cure. The International AIDS Conference in Vancouver in 1996 marked the beginning of the great success story of HEART. We've seen mortality from AIDS plummet, treatment has become simpler and less toxic, and over 5 million people in low and middle income countries are now receiving HEART. But despite these major successes, and in the absence of an effective vaccine, I argue that the need for a cure is even more urgent now in 2010 than ever before. Over the next 25 minutes, I hope to convince you why we need a cure for HIV, to explain what the current barriers to cure are, what type of cure is achievable, and finally, what strategies for cure currently look promising in the laboratory and may be close to testing in patients. So why do we need a cure for HIV? Well, despite the major successes of HEART, full life expectancy is not restored. This data comes from the Danish HIV cohort study and shows the probability of survival for 4,000 individuals with HIV compared to close to 400,000 negative controls. The probability of survival of population controls is shown in black, the probability of survival pre-HEART in blue. heart in the late 90s in orange, and heart from 2000 to 2005 in red. What's striking from this graph is a substantial increase in survival following the introduction of heart. However, even with availability of heart in the early 2000s, life expectancy remains significantly less than population controls. In fact, the chance of a person with HIV reaching the age of 70 is 50% of that of a population control. And this is in Denmark, a country with one of the best healthcare systems in the world. I don't think this is acceptable. Significant morbidity still persists on heart. There's a complex interaction between toxicity of the drugs, persistent HIV and inflammation, and ageing. And we're seeing increasing levels of cardiovascular disease, metabolic disorders, neurocognitive abnormalities, liver and renal disease, bone disorders, malignancy and frailty. This significant morbidity I don't think is acceptable. And finally, an issue that we've heard a lot about this evening, long-term heart for everyone is presenting a major challenge. For every 2 people starting heart, there are 5 new infections. We need to start heart earlier from the current recommendation of 200 to now 350, and there's an urgent need to increase coverage from the current levels of only 40%. This data shows the total projected annual AIDS resource requirements in low and middle income countries if we currently continue what we're doing, starting HIV treatment at CD4 counts of 200 and only achieving 40% heart coverage. The estimated costs by 2031 approach $25 billion. If we increase heart coverage as we should to over 80%, this figure reaches almost $35 billion. And to put that into context, AIDS treatment costs alone will account for half the US foreign aid budget by 2016. We must develop interventions that will make sure that everyone will have universal and lifetime access to heart. And in the absence of an effective vaccine, we must seriously pursue the possibility of cure. So what are the current barriers to curing HIV? This is not going to be easy. As many of you know, when antiretroviral therapy is started, viral load rapidly reduces to undetectable levels, or less than 50 copies per mil. And there's recovery of the immune system, and CD4 T cells return to normal in most individuals. However, if a patient's been on treatment for 2 years or 15 years, whether they've been on 3 drugs or 6 drugs, if they started treatment as soon as they're infected or with established infection, as soon as treatment stopped, the virus rapidly rebounds. So, of course, the big question is, where is the virus sitting while the patient has a viral load of less than 50 copies per mil? Over 10 years ago, several groups, including that of Tony Fauci, Bob Silicano and Doug Richman, identified the persistence of virus in long-lived cells, which one can measure by looking at HIV DNA. And this always remains detectable in a patient on treatment. More recently, Sarah Palmer and John Coffin have developed far better assays that measure viral load down to 1 copy per mil. And they've clearly demonstrated that in nearly all patients there is persistent low-level viremia of around 3 copies per mil. In other words, there's no such thing as an undetectable viral load. The virus persists. And the major questions is, what's contributing to this low-level viremia? What's contributing to the persistent DNA? And do we ever have a chance of eliminating it? And I think it's currently accepted that there are 3 major barriers to cure. There's a lot of debate about which might be important, but I think all of them are contributing to persistent viral replication or persistent viremia in patients on treatment. And they include latently infected T cells, residual viral replication, and anatomical reservoirs. Latently infected T cells represent the biggest challenge for us in ever finding a cure for HIV. And I'd like to spend a few minutes explaining exactly what we mean by latency. So HIV infects CD4 T cells, but it largely infects activated CD4 T cells. Most of our T cells are resting, and when they contact foreign antigen, become activated. In an activated CD4 T cell, the virus easily enters, replicates, and can produce daughter virions, and ultimately the activated infected cell dies. When a patient goes on antiretroviral therapy, subsequent rounds of replication are blocked. But in a resting CD4 T cell, HIV enters, integrates into the host genome, and can just sit there for the lifespan of the cell. It's as if HIV's gone to sleep in that cell and can wake up at any time. The origin of these latently infected cells was originally thought to be from an activated infected cell reverting to a resting state. But more recently, several groups have shown that you can cause direct infection of resting T cells that largely occurs in tissue. These latently infected T cells are extremely long-lived and therefore represent a major barrier to cure. So latently infected T cells can intermittently reduce virus into the circulation, can intermittently become activated and produce virus. But this virus doesn't go on to infect new T cells, but is a constant source of low-level viremia. We now know that the latent pool, or the number of cells that can be latently infected, is far greater than originally thought. The original descriptions identified latency in one particular subset of T cells called central memory T cells. But over the last 1 to 2 years, we've identified that latency can exist in a range of individual T cells, including transitional memory T cells, naive T cells, and most important, multiprotein progenitor cells or stem cells. And together this constitutes the latent reservoir. More importantly, recently we've learned from work from Nicolas Chamon and Rafik Sekali that these latently infected cells can also proliferate. So this presents a very daunting challenge, the number of cells in which latency can be established, and the fact that latency might in fact be perpetuated by T cell proliferation. The alternative explanation for persistent virus is that there's ongoing virus replication in activated T cells. In other words, HAART is effective, perhaps 99.9% effective, but not 100% effective. And finally, we know that HIV can hide in anatomical reservoirs, such as the brain, the gastrointestinal tract, and the genital tract. And in these sites, latently infected cells can persist, activated replicating cells can exist, as well as long-lived infected cells such as dendritic cells, macrophages and astrocytes. These sites also have unique barriers to entry of antiretroviral therapy, which limits penetration of drugs. We know that anatomical sites represent a significant viral reservoir on HAART. This data builds on earlier observations from Thi-Wook Chun and comes from Joseph Zwang's lab and looks at the number of infected cells in the gut in all levels, duodenum, terminal ileum, right colon and rectum, compared to what one sees in the blood. And in patients on antiviral treatment with undetectable viral load or a viral load less than 50 copies, there's almost 10 times as much virus sitting in the gastrointestinal tract compared to what we can find in blood. Given these significant barriers to cure, what type of cure might ultimately be achievable? The field is currently thinking about two strategies for cure. Traditional cure, or what I would call an infectious diseases model of cure, where one treats the pathogen and it disappears altogether, perhaps a lofty goal in the management of HIV. But this would require elimination of all HIV-infected cells. Patients would have to have an RNA less than 1 copy per mil, and this is now commonly referred to as sterilising cure. The alternative approach would be to aim for remission, or what one might consider a cancer model, where an individual would have long-term health in the absence of treatment, perhaps low-level viremia at less than 50 copies per mil, and this is commonly referred to as a functional cure. And there is evidence of both sterilising cure and functional cure that we need to learn from in designing new strategies for cure. Last year, there was a spectacular case report of a German patient who received a bone marrow transplantation from a donor who was resistant to HIV. The donor carried a mutation in the CCR5 gene, the major co-receptor for HIV. The patient was transplanted because of a diagnosis of leukemia and subsequently went off treatment. And multiple biopsies of the gastrointestinal tract, analysis of the CSF, and analysis of blood HIV RNA shows no detectable virus. Of course, a strategy of using transplantation with a CCR5 mutant is certainly not realistic, but we have to learn why this patient eliminated HIV. This patient tells us that latently infected cells can be eliminated, that anatomical reservoirs can decay, and that complete viral suppression without heart is possible. But we need to know why this happened in this patient. Was it the conditioning treatment the patient received for his AML or his leukemia diagnosis? Was it the transplantation from a resistant source? Elite controllers are another group that will teach us a lot about trying to achieve functional cure. Elite controllers represent a unique group of patients who are able to achieve a persistent HIV RNA less than 50 copies per mil in the absence of treatment. There's been many studies on these interesting patients from many laboratories, and consistently these studies show that a very good immune response is critical in achieving an elite control. However, I think it's important to recognise the long-term effects of low-level viremia. In a percentage of these patients, CD4 T cells are eventually lost. There is ongoing virus replication and evolution, and immune activation is also increased in these patients. So given the multiple barriers to cure, the potential targets of sterilising or functional cure, what potential strategies might we explore in the future? These strategies include optimising antiretroviral therapy through either intensification or early treatment, eliminating latently infected cells, and perhaps in the future making cells resistant to HIV. There have been a number of studies that have looked at the effects of treatment intensification on residual virus. They've included adding additional agents such as T20 or lopinavir, atazanavir or raltegravir to an already suppressive regimen. And disappointingly, we find that persistent low-level viremia continues in all of these studies, and persistent HIV DNA does not change. However, one study has shared a very important lesson with us. This is a study that comes from Spain and included 69 patients who were randomised to continue antiretroviral therapy or have the addition of raltegravir, a very potent integrase inhibitor, to their regimen. Raltegravir has the unique effect of blocking integration into the host genome, and when integration doesn't happen, a byproduct of the virus is produced, something called 2-LTR circles. So if 2-LTR circles increase, this is evidence that there is residual viral replication. And this study nicely showed in a third of patients there was a very significant increase in the number of 2-LTR circles at 2 weeks, confirming that patients still have residual viral replication. Of course, this strategy didn't actually impact on the residual virus there, but it tells us that if we're ever to use any strategies that promote viral replication, we must combine this with intensification. Early treatment may be a potential strategy to reduce or even control the viral reservoirs. This data comes from a large cohort in France, Laurent Ocalu and Christine Ruzio, who studied the size of the reservoir by measuring HIV DNA in patients with chronic infection, shown in red, and acute infection, shown in blue, after the initiation of treatment. And you can see the very marked decrease in size of the number of infected cells in patients who initiate treatment early. So again, if we're ever going to achieve a cure by reducing the size of that reservoir to potentially a manageable size or eliminating it altogether, early initiation of treatment may be a cornerstone of this approach. But the biggest challenge that stays with us is a strategy to eliminate latently infected T cells. And there are a number of potential strategies to do this. The major principle is that perhaps we could turn a latently infected cell into an activated cell. In other words, turning on T cell activation. The activated cell would produce virus, subsequent rounds of infection would be blocked by antiretroviral therapy, and the latently infected cell would die. And we already have some potential strategies that do this very effectively in the laboratory. IL-7 is one of those compounds that can very potently activate latently infected cells. And we know IL-7 is safe in patients with HIV. There were 2 studies completed last year showing that IL-7 is well tolerated and particularly induces CD4 recovery. Alternative compounds such as prostratin, not yet trialled in humans, also has a similar effect of promoting T-cell activation and eliminating latency. An alternative approach is a far more targeted approach, and that is just to turn HIV genes on. In a latently infected cell, the HIV gene is silent and turned off. And there are many compounds around now that can stimulate or turn genes on, and specifically HIV genes. And these compounds include a group of drugs called histone deacetylase inhibitors, many of which are in advanced clinical development for the treatment of cancer. One of these drugs, vorinostat, or called SAHA, is already licensed for T-cell lymphoma, is well tolerated in humans and has a very potent activity in promoting HIV or turning HIV genes on. Other drugs such as methylation inhibitors have a similar effect, and probably the most potent effect is combination therapy. And this is suggesting that perhaps to eliminate these latently infected cells, we will need to use a similar approach to what's used in cancer, multiple simultaneous strategies. I think it's important to remind you, though, that latently infected cells are rare. On average, they occur in 1 in a million or 1 in 100,000 cells. So any strategies that are not HIV specific, like the ones I've mentioned, will potentially have effects on uninfected cells, and this needs to be monitored carefully. Some potential future approaches that are currently being investigated include making cells resistant to HIV using gene therapy, and ultimately allowing for cessation of heart. Some approaches have included reducing expression of the chemokine receptor CCR5 or blocking or inhibiting HIV replication. And in the last month, there was a report in Science Translational Medicine of 4 patients with HIV and AIDS-associated lymphoma who received a transplant with these particular gene products as part of the transplant. So it was a proof of principle that these gene products can be introduced, and they actually persisted in patients for a follow-up of 2 years. Definitely a strategy for the future, a high-tech strategy which would ultimately need to be simplified, but important to demonstrate whether this may be possible in ultimately curing HIV. So we know a lot about the barriers to cure. We know a lot about potential ways we could address it, but there's still lots that we need to do. We need far better in vitro and animal models to understand how latency is established, how it's maintained, and how it can be reversed. We need far better sensitive, non-invasive ways to quantify reservoirs in vivo. We need a lot of drug development so that we can increase the specificity of current strategies we have that will just target latently infected cells, not an easy task. And we need to determine what role the immune system plays in clearing or establishing latency in reservoirs. However, there's much that we can already do now. I want to emphasise that universal access to heart still remains a major cornerstone of managing patients with HIV and will always be a major cornerstone in any strategy we develop for cure. There's an urgent need for clinical trials. We have compounds that look very promising in the laboratory, such as vorinostat and IL-7, and almost certainly these should be tested in combination with intensification and in patients who received early treatment. In the long term, a combination approach is going to be likely. We need far better community engagement in this process. The science is certainly complicated, and the interventions will be challenging in patients who already enjoy very good quality of life on antiretroviral therapy. And ultimately, we need to think carefully about what the endpoints of these clinical trials will be. Can we just assume efficacy by measuring residual viral replication, or is the ultimate test to look at cessation of treatment with its inherent associated toxicities? We need far better consortia of research networks similar to what's already established in vaccine research, not only amongst HIV researchers, but laterally amongst different disciplines. And finally, in order to achieve any of this, we need to prioritise funding to find a cure. Over the last 6 months, we've seen some tremendous innovation in funding research towards a cure. The American Foundation for AIDS Research, or AMFA, have been a real leader in this area, recently funding a collaborative network of researchers. And then NIH, just in the last 2 weeks, announced a very innovative approach, the Martin Delaney Collaboratory, a generous fund to look at public-private partnerships to develop strategies for cure. And in the strategic plan of the Office of AIDS Research for 2011, identifying reservoirs, understanding latency, strategies for cure are all identified as top priorities. However, we need significant amounts of funding to complete this work. So the International AIDS Conference in Vienna will unfortunately not be the conference that announces the cure for HIV. But we hope this meeting will mark the beginning of a future where we seriously prioritise finding a cure. We should not and cannot continue to accept that HIV is a long-term chronic illness that commits patients to lifelong treatment and associated toxicities. We should not and cannot accept that lifelong treatment may not be available to all who need it. A cure will still need a great scientific advance, but we will not achieve a cure with science alone. We need scientists, clinicians, infected communities, pharma, politicians and government to embrace the challenge. And I put to you that our goals for the future must include HIV prevention, treatment, care and cure. Thanks very much. I just want to acknowledge. I'd just like to acknowledge a number of people that assisted me with the talk, which is eliminated there, but a number of PhD students and postdocs in my laboratory. Thank you. Colleagues, collaborators and mentors, many of whom have provided data for the talk or figures or just very helpful advice in preparing the presentation. And I'd like to also thank the funding bodies who have contributed to supporting my own work on latency in reservoirs, past and present, AMFA, the National Health and Medical Research Council of Australia and the Alfred Foundation. Thank you very much.
Ladies and gentlemen, Ms. Rachel Arini.
Good evening, Vienna. Greetings to all dignitaries, my colleagues, and my friends. My name is Rachel. I'm 21 years old. I carry the voice of young people at this conference and beyond. I come from Indonesia, the largest Muslim population in the world. I come from a fundamentalist religious background, and I understand what it means to be a young woman in today's world. I have friends who have been raped, married off at young age, trafficked, and infected by HIV. Some of these things happened to me, and I was not supported to demand justice. Now, I am aware that young people have rights and that we are diverse. Today, we celebrate our diversity. Like many other young people, I live in an era when we are supposed to benefit from universal access and the ICPD action agenda. But sadly, young people's lives still remain challenged by poverty, inequality, and violence. Young people account for around 40% of new infections, but we don't account 40% of budgets and programs. The theme of this conference is right here, right now. Tonight, my peers and I urge you to become advocates for young people. We want to highlight 3 critical areas for young people. The first is that we need to fully acknowledge and protect the human rights of young people. It is sexy to say that you work with young people, but we know the truth. It is still hard to acknowledge, accept, and celebrate that young people are entitled to all human rights, including accepting our diversity and understanding the complexity of our identity. For example, our human rights cannot be fully protected if young people who use drugs cannot get clean needles. Young people living with HIV cannot choose the school they want to attend or a job they want to apply for just because a blood test is required. Our human rights cannot be fully enjoyed if young sex workers cannot access health services. Our human rights cannot be fully enjoyed if the girls and young women are not able to access legal and safe abortion services and female condoms. We long for comprehensive sexual and reproductive health services. Identity is complex. Young people are more than just a number in epidemiology. We need to avoid labeling. We must respect the diversity of young people. We must eliminate policies that discriminate against us. We demand more inclusive and progressive agendas that recognize sexual rights and sexual diversity. The second area is access to information and services. When I was 15, my teacher gathered us for a special meeting. A male guest in doctor's coat, accompanied by our imam, told us that the condom campaign was only a propaganda to make people lose faith in God and turn us into sinners. No girls could ask questions because they'd say only boys were at risk. This is my sexual education. Yet, I was refused by the clinics when I went for HIV testing. They said I am too young and I'm not married, and not to mention our struggle to access ARV. But I know that I'm also too young to die of AIDS. I realized that sometimes what is written on paper, even international agreements, can be useless. We have to do better than this. We call on decision makers to provide evidence-based, comprehensive sexuality education for young people, both in and out of school. They should recognize the rights of young people to enjoy their sexuality in a safe and pleasurable ways, free from coercion, discriminations, and violence. We call on decision makers to provide comprehensive youth-friendly HIV care services and support that actually can be accessed by young people. Those services should be delivered by trained health providers who respect the diversity and rights of confidentiality of young people. To achieve this, we must eliminate legal barriers such as age, parental, and spousal consent. The third area is sustaining young people leadership. Young people involvement is crucial. We believe we are capable of reversing the impact of HIV epidemics, and the new UNAIDS data is supporting this. More and more youth leaders and activists have taken steps to build their own responses. They have established their own networks, called for strong youth leadership, mobilized resources, and promoted meaningful youth participations. We are already out there. We just need to be recognized, respected, and supported. Most youth-led networks and initiatives are informal and run by volunteers, but we are flexible, non-hierarchical, creative, and open to collaborate. Sadly, we almost always have no funding for operational costs. As with any HIV programs, we have to acknowledge that one size doesn't fit for all. But today's donor architecture often only recognizes one size fits all. I want to echo the community concern. Broken promise kills. We should put health resources as country priorities. We call for more sustainable fundings for programs and treatment, which includes core funding for initiatives and network. All of these three areas cannot be achieved without meaningful youth participations. We call for meaningful involvement of young people in the development of programs, budget, and policy. But especially, we want a seat at the table to make a decision, a seat in the table to make a decision, and not making photocopies and coffee. In order to realize right here, right now for young people, we demand that you to invest in young people leaderships, especially the leadership of young women and girls. We hope the new UN entity for women creates a formal platform for young women and girls to meaningfully participate at every level. We need intergenerational approaches that foster transparencies, accountabilities, and support of our networks. We need a mentorship and also a partnerships, not just a jargon. My peers and I will not only be the leaders of tomorrows, we are the leaders for today. We intend to work together for rights here, right now for all. And now, I have to challenge you. I have to challenge you to follow up all the commitment in this conference, to make this conference not to become just another conference, to translate from paper to people, and now make it happen. And good luck for Women Arise for the upcoming activity. Best of luck.
The Executive Director of the United Nations Joint Programme on HIV/AIDS, Mr. Michel Sidibe.
As I said in Washington, D.C., women deliver. Women deliver. Good evening. Ladies and gentlemen, it is my honor to address you for the first time as the head of UNAIDS. Thank you. Thank you. Thank you for your tireless work. Like me, you're here because you believe that we can end this epidemic. Because you wake up every day ready to continue fighting for a world without AIDS. On behalf of the UN Secretary General, Ban Ki-moon, and the 10 UNAIDS co-sponsors, I thank the city of Vienna, the Austrian government, and the International AIDS Society. From Vancouver in 1996 to Vienna, we have achieved great things together. The conspiracy of silence has been broken. 5 million people are alive because of treatment. Infection rates have dropped 17% since 2001. We have seen unprecedented activism and the full engagement of people living with HIV. But I am scared by what I see today. Prevention models are coming up short. Some governments are cracking down on vulnerable groups. Treatment is not sustainable. Costs are rising. Countries like Brazil have seen treatment costs go full circle, from high to low to high again. Meanwhile, 10 million people are waiting for any treatment at all. They are afraid for their future, for their lives, and are trying to not lose hope. In Vienna, we are at a defining moment. Millions more will die if we keep offering only a jumbled mix of uncoordinated, underfunded, and underutilized services. For the first time in a decade, an investment have not grown. The hopes of millions were put on hold when the G8 abandoned any reference to the financial commitment they made in Gleneagles. I'm not just addressing donor countries. Developing countries need to keep their commitment too. The 15% promise made in Abuja must not be buried. It is about sharing the responsibility we have to the world. The financial crisis should not be an excuse to flatline or scale back. In fact, it is an opportunity for new sources of funding, like a levy on global financial transactions, a Robin Hood tax. Now, it is the time to face up to our responsibilities, to show integrity, to keep our commitments, to demonstrate that we can build a society where we will democratize problem solving and be more nimble like Haiti. We need to listen to those affected by epidemic or natural disaster. It is time to empower communities to lead and own the response. We cannot settle for a world where some people get treatment while others do not, where some enjoy access to prevention while others are criminalized for who they are and who they love. Where some are offered hope while the hope of others is crushed. Our vision must be uncompromising. We want nothing less than zero new HIV infections, zero discrimination, zero AIDS-related deaths. We have a plan, 4 pillars that are fundamental to achieve this vision. A prevention revolution, new models for treatment, full equality for women and girls, ending discrimination. First, I have called for a prevention revolution, a global political and social movement, one rooted in human rights and gender equality. Without a vaccine or a cure, the AIDS pandemic will become unmanageable unless we drastically and quickly reduce the transmission rate. In 2008, 1.4 million more people were newly infected than started treatment. This trajectory must be broken, or the world will need to find the resources to treat 2 million more people every year, every day, for the rest of their lives. Better prevention research will break the trajectory of this epidemic. We have evidence of the impact of concurrent partnerships and the value of intervention like male circumcision. Now we have to put this evidence to work. I share Anthony Fauci's optimism that ongoing high-risk, high-impact research is finally going to put all of us out of work. PrEP, microbicides, and using ARV to prevent transmission are not showstoppers on their own, but all take their place in our arsenal of combination prevention. Young people are leading this prevention revolution. HIV prevalence dropped among youth in 15 of the highest burden countries. We need to continue to empower them with a sexuality education that builds life skills. Their energy and bold ideas have inspired me in Vienna. I have taken to heart their slogan, "Now make it happen." Now make it happen. Treatment 2.0. The next generation of treatment is the second pillar. Treatment is a right. Treatment is a smart investment that reduces HIV transmission, TB, and maternal and child deaths. Thanks to the support of British Columbia Premier Campbell and the dedication of Julio Montani, the world now knows that treatment for prevention is a reality that works for the 3 Ps. It works for the patient, it works for the pupil, and it works for the pocket. Treatment 2.0 radically simplifies treatment approaches to maximize the number of people who can benefit. This will save more money, but in the end, we will only be measured by the number of lives we save. Treatment 2.0 calls for bold new partnerships with the pharmaceutical industry and to exploit the full use of TRIPS to vastly scale up access. I believe so strongly in Treatment 2.0 that I am putting my authority as the head of UNAIDS behind it. With the joint leadership of Margaret Chan, WHO and UNAIDS will direct country-level representatives to sit down with their national partners to explain the meaning and importance of 2.0. We will ask our global partners, PEPFAR, the Global Fund, UNITED, the Clinton and Gates Foundation, President Mohai HIV Champions, and others to work with heads of state, ministers of finance, minister of health, and civil society to take up the banner of Treatment 2.0. As the third pillar, we must end discrimination. Instead of universal access, the people who suffer most face universal obstacles. No one should endure discrimination. Not men who have sex with men, not transgender people, not sex workers, not people who inject drugs, not prisoners, not especially people living with HIV. Eastern Europe has some of the highest concentrations of HIV among people who inject drugs. This epidemic is inflamed by stigma and punitive laws and won't stop burning until harm reduction and drug substitution programs are scaled up. The US government took a historic step this week with the announcement that PEPFAR will now support needle exchange and substitution therapy. Laws must work for all the vulnerable people, not against them. An injustice to one is an injustice to all. The fourth pillar is gender equality. The research of Rachel Jukes has highlighted how so many high-profile AIDS responses focus on men. Even though most new infections in high-prevalence areas are among women, meanwhile, society turns a blind eye to the gender violence that makes women and girls more vulnerable. Gender equality must become part of our DNA. Women must have better tools to protect themselves from HIV, like microbicides and female condoms. They must have the rights, the skills, and the power to negotiate their own sexuality. And they must feel safe from violence. The research shows that traditional HIV intervention don't work when intimate partner violence is present. UNAIDS will ransack every strategy to find what will. Integration is the only way forward. AIDS response should be the bridge joining others' movement, maternal and child health, sexual and reproductive health, women's rights, and even the fight against women's cancer. We must move past the dangerous notion that health priorities steal from each other. On the contrary, when we take AIDS out of isolation, AIDS and other health movements strengthen each other. They strengthen health systems, and they transform communities from passive beneficiaries to actors of change. On this road to zero, we cannot turn back or turn our backs on the people and problems in our path. 10 million still need treatment. For every 2 people starting treatment, 5 more are newly infected. More than 80 countries have homophobic laws. And still, babies are being born infected and are dying before their second birthday. An AIDS-free generation is so close at hand. We cannot stumble. There is more at stake here than newborn's life. It is their mother's life also. We must never lose sight that women who gave birth must also survive. The virtual elimination of mother-to-child transmission by 2015 is a sacrosanct. My friends, there is so much hope on the horizon. The bold leadership of South Africa giving AIDS historic attention. The timely move by China to lift HIV travel restriction. Treatment as prevention. A possible breakthrough on vaccines. Young people taking action and bringing their prevalence rate down. And every day scientists edge closer to a cure. You just heard the last presentation. This idea that we should cut back or slow down now is ridiculous. The 0 hour approaches, and when I think of that day, I imagine living out the words of Ted Kennedy. There were hard hours on our journey, and often we sail against the wind, but always we kept our rudder true. And there were so many of you who stayed the course and share our hope. You gave your help, but even more, you gave your hearts. My fellow activists, keep giving your hearts. Thank you. Thank you. Thank you, thank you. I want you to join me also to wish happy birthday to my hero, Mandela Madiba. Happy birthday, Mandela.
Ms. Paula Akugiziwe will now deliver the third plenary presentation on the state of the epidemic.
Good evening. Thank you.
Rubbing on that Italian leather, them convict jeans on. Hey, yo, Weezy, you ready? Yeah. I get it until the sunrise. Throwing 90 in the 65. Windows roll down, screaming now. Number one hustler, getting money. Why you wanna count my money? I'm a hustler and don't need man one of y'all, you see. I'm the boss, it only takes one call for Jai to hit you up and dump you off, and that's all. Guess what? I won't be taking that fall. Homie, I got cake, that's what I'm paying them for. Haha, ain't that funny? Gorillas, they want war, but ain't got money. Cause I seen them all talk until they start gunning. Quicker than Usain Bolt, the fastest thing running. Yeah, Akon, Weezy, Block Royal holding down Jersey. Divine making sure we getting it up front. My little brother Boo got that vision, baby.
I want to start off by emphasizing that the message that opened the conference this evening is possibly the most important message that we'll hear over the next few days, regardless of what specific issue we're addressing. We need to see accountability. Broken promises kill, whether it's with regards to funding, to quality of evidence-based interventions. We need to keep the promises that we have made, and we need to keep funding universal access.
10 years ago, the Durban Declaration, the historic Durban AIDS Conference in South Africa, ended with the statement that by working together, we have the power to reverse the tide of this epidemic. Science will one day triumph over AIDS, just as it did over smallpox. Curbing the spread of HIV will be the first step, and until then, reason, solidarity, political will, and courage must be our partners. So here we are 10 years later, the year that we were supposed to be celebrating universal access, but are instead having to stage die-ins outside the International AIDS Conference to draw attention to the fact that already, despite the fact that we're less than halfway to realizing this triumph over AIDS, the political will, the courage, the solidarity that we had thought would be necessary and had thought would see us through to the end have already begun to wane. So here we have about 20 to 25,000 participants from about 100 countries around the world. And if we make a conservative estimate of about $2,000 per participant, including travel, accommodation, registration, and so on, which I'm sure you all agree is a very conservative estimate, and we work out the total that this cost, it's 20% of the total money that was given by the Global Fund in Round 9 to the Southern African region for all 3 diseases in 7 countries in Southern Africa. Not just that, but as has been stated on one of the Austrian government sites, AIDS 2010 is also of great importance to Vienna as a conference center. The current prognosis is for the conference to contribute a total of 45 million euro to Austria's gross domestic product. What's the moral of the story? We'll come back to that later. Let's start off by establishing the common ground that we all have here this evening. We're all here because we have a shared vision, namely gathered around Millennium Development Goal 6, which is to curb the spread of HIV, TB, and other infectious diseases, and to realize universal access, although the precise definition of that may be debatable and needs to be clarified, but to realize universal access to HIV prevention, treatment, and care for all of those who need it. This is not an unattainable goal. As has been said by Ban Ki-moon in this year's Millennium Development Goal report, yes, we can achieve this goal. He says the world possesses the resources and the knowledge to ensure that even the poorest countries and others held back by disease, geographic isolation, or civil strife can be empowered to achieve the MDGs. So even in the worst circumstances that one could imagine, these goals are imminently attainable. So what's going wrong? Development and implementation of successful interventions requires the resources and knowledge that are referred to in this statement. But additionally, especially when it comes to the context of HIV and human rights, particularly with regards to HIV, the make or break at the end of the day is not just about collective knowledge and collective resources. The make or the break ultimately comes down to individual level decisions. The decision to use a condom when having sex, the decision to get tested, the decision to initiate treatment and adhere to it, the decision to travel 200 kilometers or however far it is to get to your nearest facility where you can get your CD4 monitored. These are all the decisions that make or break the HIV epidemic on a daily basis. But it's important for us to realize that because of the context, the social, the legal, cultural, economic context within which these interventions are being implemented, often these decisions are not just a matter of the one person involved, because we're dealing with human beings, and ultimately the HIV response is not about microbes, it's about humans who live in human realities. And these realities come with social dimensions, cultural, economic, and political dimensions. And ultimately, because of failing to address this, we have put people inside a limited framework that chooses for them what decisions they can make, what access to services they can have. And yet, at the same time, we claim to be committed to universal access. And so we welcome the theme of the International AIDS Conference because for too long we've seen a false divide between human rights and science. We've seen allegations that human rights holds back progress on scientific interventions. But at the end of the day, we're all working towards the same thing. We know what we want to achieve. So the question that we all need to agree on now is how do we get there? If science is the engine of the human rights response, then the engine of the HIV response, then human rights are the vehicle that take us forward. Resources are the fuel, and accountability Accountability is the driver, and we need all of these together in order for us to make progress. If anyone is missing, then we're going nowhere. And so here we are in 2010, a critical year, and are we making or breaking? As you can see from this snippet of stories over the past few months, many of the challenges that we're facing in 2010 with making the best possible use of the tools that we already have are not fundamentally scientific challenges. Yes, absolutely, we need more research, and we would all like to see the day when there's a cure for HIV or a vaccine for HIV. But right now, with what we do have, we could be doing a lot more. And the reason why we're not doing as much as we could, fundamentally, are political, social, economic, and cultural problems. So today I'm going to speak about how human rights have shaped the state of the epidemic. And I'll speak in three main areas. Firstly, our ability to reach and engage people where they are. Secondly, our ability to nurture a sustained sense of shared responsibility for the HIV response. And thirdly, accountability, both with regards to funding as well as the implementation of evidence-based approaches. Let's start with the foundation, the right to health. I want to ask by show of hands how many people sitting here in the room today believe that health is a human right? It seems like just about everyone does. And yet, if you look at the policies, the constitutions of many of our governments around the world, they do not reflect this belief. It's interesting to note that the global HIV response was originally rooted in a recognition of the right to health. It was unprecedented in the history of public health for so many governments and people around the world to mobilize billions of dollars into a multilateral initiative such as the Global Fund to respond to a global disease. And this happened because millions of people around the world mobilized around the right to health and how it relates to the right to life. But unfortunately, this has not happened so much at the national level. And because of the absence of legally enforceable provisions at the national level, our ability to sustain this energy is flimsy and is not predictable. Last year, the World Bank and UNAIDS did a survey to see which of the countries believed that the HIV response would be under threat in the coming year because of the economic crisis. And they found that national recognition of the right to health was one of the key three predictors of sustainability for HIV treatment programs at a time of economic crisis. So lack of recognition of the right to health doesn't only create unpredictability in our response, but it also creates hierarchies of access, where governments can decide based on their own subjective political whim who is more entitled to the right to health, and thus who is more entitled to the right to live. And through this, we end up seeing groups of people who are most needing of particular interventions, but are systematically excluded from receiving them. If we talk about universal access, it has to be universal, and we will never manage to get anywhere near the indicators we're trying to reach as long as we have specific people being left out in a systematic way. So let's look at ways in which human rights have worked for us. Access to essential medicines, TRIPS flexibilities. The whole rationale behind this was that people's rights, human rights, the rights of people who need access to medicines need to be prioritized over the profit rights of pharmaceutical companies. And as a result, we've seen remarkable gains in reductions in ARV prices over the past 10 years, reducing almost 100-fold in some cases, meaning that many people who would never have had access to life-saving medicine were able to afford it. But because of lack of this principle at the national level, lack of an understanding of the importance to ensure the right to health and access to health services, we're seeing that many of these gains are threatened at the regional international level. Some examples being some of the intellectual property agreements or economic partnership agreements that are being set up with the European Union and other countries. And I was interested to hear the European Commissioner for Health saying that HIV treatment must be universally available and accessible, because we've seen concerns in the past year with this very treatment being confiscated and held here in this very continent when it's on its way to meet people who need it in order to stay alive. There doesn't seem to be much consistency in that. Within countries that need access to medicines as well, we've seen challenges with regional laws, such as the anti-counterfeit bill in Kenya that threaten access to generic medicines, which in itself is not a bad law, but somehow, intentionally or otherwise, groups generic medicines as part of counterfeit medicine and might thus threaten access in future. People living with HIV have taken the government to court based on the human right to health and the human right to life. And so far, the ruling is in favor, and we call on the Kenyan government to ensure that when the final decision is handed down, it does not violate the rights of people living with HIV to access generic medicines. So in contrast to seeing rights in action and the positive impact that we've had as a result, we also have many more examples of rights in action and the devastating impact that this has. And one of the most talked examples is that of prisons. In most places in the world, if you're sentenced to spend time in prison today, you're also sentenced to disease, you're sentenced to HIV, TB, and very little chance of accessing testing, treatment, and care. And one has to wonder how prisoners being subjected to a series of human rights violations are expected to be rehabilitated within these systems. We see gross lack of HIV, TB prevention, testing and treatment measures in prisons, lack of condoms, although we know it is a reality that sex happens in prisons, and that it happens because in many cases it happens because other rights are being violated, because there's overcrowding, because people don't have access to food or water, and as a result they have to have sex as a transactional way of getting access to these essential things that they need to stay alive. It's been estimated that 27% of US inmates experience sexual violence. And across the world, we see that the challenges faced by prisons overlap with other rights challenges in the HIV response, such as injecting drug use. On HIV, UNAIDS and UNODC say that we have insufficient knowledge, but what we do know is alarming. And rates in prisons could be up to 50 times general population rates. TB incidents could be 10 to 100 times the general population. Every year, 30 million people go through the prison system. And at any given time, there's only several million people who are actually in prison. So all the rest of these people are coming through the system where they're exposed to these high risks and then coming back into the communities, which is why prisons have often been described as epidemiological pumps or reservoirs of disease. It is a human rights violation, but from a public health perspective, it's also completely irrational. We also see challenges with migrants, and I asked a few activists from the Southern African region if they had one story and one message they'd like to send to the International AIDS Conference, what would it be? This story came from Botswana, of a man called Isaac, who's been in a long-term relationship with a Zimbabwean woman who was unable to access PMTCT because she's not a citizen of Botswana. As a result, when they had their son, Otsile, in 2007, he was born with HIV in a country that has one of the most advanced HIV treatment programs on the African continent. He did not inherit Botswana citizenship for whatever reason, and therefore he himself was unable to access ART. When he fell sick, Isaac could not watch his only son die, and he started sharing his ARVs with his child. Eventually, the child died, and Isaac has now developed drug-resistant HIV. And Cindy says, the last time we spoke to Isaac, he said, "I can't believe my own government that I voted into power discriminated my own flesh and blood. How much could it have cost to save my child's life? What could have become of my child's life?" She goes on to say that as long as African governments fail to meet their Abuja commitments, and as long as donors continue to scale back on their commitments to funding universal access, organizations such as hers, Bonella in Botswana, will not be able to challenge these discriminations because ultimately it comes down to priorities with our national resource allocation. Systematic marginalization precludes universal access. As long as we have violation of rights that are entrenched in punitive laws, we will have access barriers for key populations. And you can see here that many countries around the world report that they do have laws that preclude access for drug users, for men having sex with men, for sex workers. And even this reporting we can see is not quite up to scratch, because if you look at the African region, we know that many more countries have laws that prohibit same-sex relationships than are reflected in this graph. And while we welcome the increasing recognition of the need for interventions for these groups, such as the establishment of a global fund reserve in round 10 for most at-risk populations, we also need to recognize that this is not just about a public health approach, that the risk and prevalence that these groups face are not inevitable, but they're the results of political, social, cultural frameworks. And until we can address these from a human rights-based perspective, our public health interventions will have limited reach. The fundamental principle of rights is that of equality, and this includes equal protection of the right to health, regardless of subjective opinions on morality. And this is not just a human rights angle, but it's also supported by public health rationale. As we can see here, drug users, MSM, and sex workers contribute a large part of the prevalence in many regions of the world. Let's talk about drug use in Eastern Europe. We've all heard about the Vienna Declaration and the previous speakers, which opens with a statement that the criminalization of illicit drug users is fueling the HIV epidemic and has resulted in overwhelmingly negative health and social consequences. A full policy reorientation is needed. We have the fastest growing epidemic in the world here, 66 prevalent increase over the past few years, and we have a huge amount of this incidence being related to drug use. And yet drug users often don't receive prevention interventions such as clean needles. And not only that, but they're least likely to access ART, although there's no evidence to support the prejudiced assumption that they are at increased risk of resistance because of the fact that they won't adhere to treatment. Research has shown that this is not the case. So the rights-based approach calls for harm reduction, which includes needle exchange as well as opioid substitution programs. Scientifically, it's very sound. This graph shows that we could reduce incidence by 50% if we scaled up opioid programs by 50%. But politically, unfortunately, we find that it's still unpalatable. Let's talk about human rights and LGBTI. 86 countries around the world criminalize same-sex relationships. And this is not just a matter of law and policy, as many people tend to think. It's actually an epidemic of societal homophobia based on pseudo-religious and cultural arguments. And I won't get into those now. You're welcome to visit the Erasmus stall if you'd like to know more about how we're attempting to respond to this. But ultimately, these arguments that were designed to explain why people who are engaged in consensual same-sex relationships should not have the equal rights that the rest of us enjoy, has dramatic implications, firstly, for the ability to engage in healthy relationships, for the experiences of homophobia and the way that this impacts the sexual relationships, sexual violence. We've heard of correctional rape being implemented in some countries where people who are in same-sex relationships are raped as a way of attempting to desensitize them to these practices. It makes no sense, and it spreads HIV. And finally, decreased access to HIV services because of the stigma that they face. As a result, we see prevalence levels are much higher among sexual minorities, particularly MSM in the sub-Saharan African region. But in many other groups, there's very little known about transmission because these groups are not prioritized. Here's another story of someone from Cameroon who was arrested and spent a year in prison because the law prohibits same-sex relationships, where HIV prevention and treatment are not readily available. 10 days after his release from prison, he died of AIDS-related complications. And the message from Chief Willie from the International Gay and Lesbian Human Rights Commission is that homophobic stigma and denial have pushed the issue of same-sex HIV transmission firmly into the closet. The needs of African same-sex practicing people are off the map that governments and civil society have drawn to guide national and regional HIV strategies. Political and cultural resistance to acknowledging African homosexualities and the resulting invisibilization of same-sex practicing people are contributing to widespread human rights abuses and increasing vulnerability to HIV. Let's talk about sex work as well, which we've heard very little about so far. UNAIDS has said that the rights-based approach calls for recognition of agency over one's body and choices. And this includes the choice of work, because sex work is work. It's just that the work that it involves is sex, much like some marriages, some might say, without the paperwork. So there's no logical reason why we should criminalize against this particular group, apart from our own prejudiced notions of what morality is. Criminalization renders sex workers vulnerable to violence. It compromises their ability to negotiate condom use, and it ostracizes them from access to health and justice. And as a result, prevalence rates are about 75% in some populations because of this criminalization. And despite the fact that they have such high prevalence rates, sex work and HIV receives less than 1% of the global resources. There is no rationality in this. In countries that have taken the courageous steps, such as New Zealand, of decriminalizing sex work, the impacts have been astonishing, both with regards to increased condom use, as well as the perception of the right to refuse sex, which in many countries where sex work is criminalized is not a right that's recognized. And finally, it expands opportunities for sex workers to consider other professions if they should choose to do so in future, because it doesn't come with a criminal record. Human rights and gender, we've heard a lot about women, so I won't talk about this at length, but we need to emphasize that the challenges we see with HIV among women, especially in the sub-Saharan African region, but really in many other regions across the world, need to be placed within the broader context of structural inequalities, of sexual violence, economic dependency, and unequal access to medicine. And the HIV response cannot divorce itself from these realities, and nor can it continue if it only pays them lip service. As has been said in the MDG report, gender equality and the empowerment of women are at the heart of the MDGs and are preconditions for overcoming poverty, hunger, and disease. But progress has been sluggish on all fronts, from education to access to political decision-making, as we can see by this diagram showing how many women are in positions of decision-making power in countries around the world. We also need to recognize that the discourse on gender creates cultural tensions and that we need to find ways of engagement that are not didactic, but actually create safe spaces for people to talk. And additionally, the divisionism that we've seen now as part of the backlash on HIV funding, which states that we need to take money away from HIV in order to focus on maternal health and on child health, is really a false dichotomy and a very dangerous one, because maternal mortality in many regions in the world could be significantly reduced by ensuring that universal coverage of HIV services is available to all women. But unfortunately, this is not the case. PMTCT has scaled up at a very slow rate, particularly in the African region, but in many other regions as well. Reproductive rights were under threat in the early days of the HIV epidemic, but continue to be under threat. And initially, the pretext that was given for this was that there's a risk of vertical transmission. PMTCT has resolved this dilemma, but there's been a delay in scaling it up, and as a result, we still see that 1,200 children are born with HIV daily, that access to maternal health and antenatal care remains very low. And we continue to see social stigmatization of pregnant women living with HIV, which in itself presents a deterrent to access. Recently in Namibia, we've seen that even where there is considerable scale-up of PMTCT, there are extreme measures to curtail reproductive rights, such as forced sterilization of women who report to hospitals needing care, and in order for them to receive the care, are forced to consent to sterilization to prevent them having children in future because they're living with HIV. How do we expect people to be drawn to services when this is the sort of stigma that we're offering them in return? Ending vertical transmission, do coercive approaches have a place? I would just like to emphasize here that getting pregnant women to test for HIV, which some countries have chosen to do in a mandatory fashion, is only the first step of a multiple-step journey. And that if we ostracize and antagonize people at this step, we break down the system every other point of the way. As this systematic review showed, the main reasons for people not engaging with PMTCT right through to its conclusion are poor understanding, patient denial, and fear of stigma. We cannot adopt public health approaches that ignore these realities. And Jonathan Mann, the former head of HIV at the WHO, spoke with some prophetic insight when he said in 1987 that the epidemic of stigma, discrimination, and denial is as central to the global AIDS challenge as the disease itself. We need to start learning these lessons. We cannot control HIV/TB through coercive approaches. We cannot force people to get tested for public health rationale, because ultimately this pushes people away from the services to which we're attempting to draw them. But unfortunately, examples in the region, Lesotho, Swaziland, and South Africa, anecdotal evidence has suggested that this happens in the context of universal testing campaigns, often because healthcare workers don't receive adequate training and sensitization. There is no rationality in forcibly entering people into a program when at the end of the day, they're not going to be able to see through the lifelong commitment that one needs to ensure the positive benefit of HIV services because of the fact that their rights have been violated. Criminalization is becoming more popular in countries around the world. Ostensibly, it's meant to encourage disclosure, it's meant to protect women, but often it has the opposite effect. It reinforces stigma. It particularly affects women because they themselves are often at risk because they cannot negotiate safe sex because of fear of violence, or they cannot disclose their HIV status because of fear of violence. So the very objectives that we're using to defend this stance often have the precise opposite outcome when we look at what happens in reality. Criminal law, as it was said a couple of years ago, cannot draw reasonable, enforceable lines between criminal and non-criminal behavior, nor can it protect individuals or society from HIV transmission. In the protection of women, it is a poor substitute for policies that go to the roots of subordination and gender-based violence. The use of criminal law to address HIV is inappropriate except in rare cases. And similarly, the use of criminal law to control TB is inappropriate. And this is something that's been recognized by the WHO in the most recent guidelines. We know that TB, HIV are essentially co-epidemics, particularly in Southern Africa, which is where I'm based. And we've started to see governments attempting to clamp down on transmission of TB by forcibly isolating people in facilities. In some parts of the world, like Ukraine, a lot of TB patients, not just drug-resistant TB patients, are kept in isolation facilities. Many models around the world have shown that community-based care has preferable outcomes, not just from a human rights, but also from a public health perspective. And yet we're still practicing mandatory isolation, regardless of infrastructural capacity, which is a lot more costly than treating people in the communities, in their homes, in a manner that respects their rights. There is no rationality in this. And there's no rationality in our continued refusal of many national HIV programs to address the socio-economic context in which HIV interventions are being implemented. Why is it that, as this systematic review shows, 2 years after initiation of people on ART in sub-Saharan Africa, we have an average of 60% retention in ARV programs? Simply giving people services is one thing, but in order to retain them within these services, we need to make sure that we address the challenges that they face, such as food insecurity, distance to healthcare facilities, stigma and discrimination. These are things that come up repeatedly, but still somehow have not found the way to the center of the way in which we design our responses. And so we're hearing a lot about bold and radical new strategies. We're entering a brave new world of treatment 2.0, of many other new biomedical approaches that, yes, are welcome and are necessary, but the question from a human rights perspective is what has happened to the same old problems that we have been facing? How can we focus on bold new interventions before we have addressed a lot of these very fundamental social, economic, and political challenges that have really been the fundamental shortcomings in the response to HIV? This is a staggering and a costly rationality, and we would do well to heed the words of Marcos Espinal, who said earlier this year that TB is not a medical problem. It's a development issue, it's an economic problem, and it's a human rights situation. The same thing could apply to HIV. And in closing, I just want to bring us back to our original, to where we started on the issue of funding and irrationalities and rights. I'm not an economist, so I've borrowed, time's up. Okay. Excuse me, I'm just going to be a few more minutes. I think it's very important this message gets emphasized. We are making decisions to cut back on funding that are not just going to violate people's rights, people's access to health, but are ultimately going to be very foolish economic decisions, as is evidenced by these statements from African heads of state and from the World Bank. The global economic crisis is not the thing that is threatening the fight against AIDS. It's a global priorities crisis that is threatening the fight against all MDGs. The issue is not that HIV is overfunded, the issue is that health is underfunded, and it's underfunded because we do not prioritize it. Because we'd rather prioritize competing political interests. And these are some of the things that we seem to have a lot of funding for: political luxury vehicles, for military expenditure, for politicians' pay, for World Cup stadiums. But when it comes to health, we have to beg, borrow, and steal. There's very little rationality in that. In closing, I want us to just consider this situation where you have a government that instructs implementing countries that they should not enroll new people on HIV life-saving treatment unless other people have died to create gaps in programs for them. You have a government that just a few weeks before they host the International AIDS Conference writes to the Global Fund to say that health is not a thematic priority of the Austrian Development Corporation, and therefore they cannot make any contributions to the Global Fund over the next few years, although they'll be making 45 million euro from this conference. You have a government that's stolen billions of dollars from health donors and are yet to pay half of its money back. And then you have activists who visit the World Economic Forum to deliver a memorandum emphasizing that health is wealth. You have Iranian doctors who have the medical integrity, the courage, and the humanity to provide treatment to people in a country that stigmatizes HIV at the highest levels. And the question that I ask you as intelligent, rational, and humane human beings, which I assume that all of us in this room are, is who are the criminals in this context? I'll give you a clue. It's those ones circled in red. And the point of this, the moral of this story, is that something is going very wrong in accountability, in the way that we approach the HIV response. And we need to start looking, as we call for more funding, we need to start looking at what we do much more critically. We need to remember that the theme of this conference, human rights, is not just about having all these rights-based interventions, but ultimately that the human rights-based approach calls on all of us as human beings to accept our own individual sense of responsibility, not as bureaucrats, not as clinicians, not as researchers, as humans. And therefore, whatever we discuss over the next few days cannot end here. We each have an individual responsibility to take it back to where we came from. And if we all believe that the right to health is a reality, is a human right, then we need to go back to our countries and we need to make sure that the resources, the types of interventions that are implemented over the next few years recognize this right. Apologies for going over time. Thank you.
Annie Lennox, singer, songwriter, and longtime activist, founder of the Sing Campaign and international UNAIDS ambassador.
Good evening, everybody. It is absolutely wonderful to be here, along with my fellow activists, friends, and campaigners. It's an honour and a privilege to be able to address you here at the 18th Global AIDS Conference. I've been campaigning on the issue of HIV and AIDS since 2003, when I was invited to take part in the launch of Nelson Mandela's 46664 HIV/AIDS campaign, and a concert that was held in Cape Town in South Africa. And really my life changed from that point on. We were invited, that is the artists, to join with Nelson Mandela the following day on Robben Island, the place where Madiba had been incarcerated for so many years. He stood in the former prison exercise yard of the prison and addressed the world's press, describing the HIV/AIDS pandemic as a genocide that was affecting women and children at an insurmountable rate. This word, genocide, shook me for various reasons, one of them being this. This was Nelson Mandela, one of the most revered and respected individuals on the planet, describing the HIV/AIDS pandemic as a genocide. And I thought, I haven't heard that before. Who's listening? Who's responding? We are the people here tonight who have responded and who are continuing to respond. And I took a pledge in that moment when I understood that I would respond, that I would become a campaigner because of my gender initially, because I am a woman and women are being affected at such a tremendous rate. The face of AIDS has changed dramatically since the 80s. I have had the privilege of great medical care, all the things that we are talking about human rights earlier. We in the West, we live in a bubble of human rights actually. We are used to human rights. But when I look at my gender in other countries, in developing countries, in places like sub-Saharan Africa, where is the protection of my gender's human rights? And how could it be that the Rainbow Nation in South Africa, the country that had given us so much hope, over despair, despair at apartheid. How could it be that on a daily basis, for over a decade, almost 1,000 people dying, mothers leaving millions of orphaned children behind? How could that be? Are we not enraged? Do they not have the right to life? I joined Treatment Action Campaign. I became a very active campaigner. I spoke up and continue to speak up about the issue that profoundly affects me. And I look on this issue of HIV and AIDS very much in parallel with the anti-apartheid movement. I was hugely inspired today to witness the Deputy President of South Africa standing on the stage alongside the Director of UNAIDS, Michel Sidibe. That was a historical moment, and one that we must not forget. It signifies a huge change in the sense of the commitment of the South African government once and for all to roll up its sleeves and to acknowledge the pandemic and to commit to making significant change. And we must celebrate that. We must celebrate that. We must see it as a positive step. We must support the South African government in all its attempts. It's a huge challenge, but we must see this as a light, as a beacon of hope over despair, just in the same way that Nelson Mandela and the anti-apartheid movement and the ANC and all the people that fought against apartheid are a very special symbol of hope over despair. Let us recommit this year, in 2010, to doubling and strengthening our efforts of support and making sure that the message reaches the people who need to hear it, the governments, government leaders, civil society, all the people that can make the difference. And the difference can be made. And I'm going to illustrate that with you now. I want to share the story of a little girl. Her name is Avalile. Avalile's story travels with me wherever I go, and I campaign all over the world. This is a photograph of Avalile, a little girl who was born HIV positive. Avalile's mother died of AIDS. This child in this photograph is weighing less than a 1-year-old baby. Avalile in this photograph is struggling to survive. She has full-blown AIDS and pneumonia. Avalile represents millions of children in sub-Saharan Africa and in other parts of the world. And in this instance, Avalile had access to good medical care and nutrition. 5 months after this photograph was taken, we went back to the Eastern Cape where she was living. And I want to share the photograph of her transformation with you now. Isn't that inspiring? Doesn't that make you feel that every single moment that you have spent campaigning and working on behalf of people who are struggling with this issue, doesn't it make it seem worthwhile? Don't you think her life is worth saving? Everywhere I go, I wear my HIV positive t-shirt. It is my tool so that when people take my photograph, it's not just a picture of Annie Lennox. It's a picture of a woman standing in solidarity with every single person in the world who is suffering with this virus. It should not be stigmatized. It must come out of the closet and be normalized. That is the message. There should be no more shame at HIV. So let's not wait for another 10 years. Let's not wait for 5 years. Let's not even wait for one more day. Let's commit here and now, here in Vienna. Let's recommit to all the work that we have done and we will continue to do until we see universal access. It is achievable. It can be done. Thank you.
His Excellency, Dr. Kgalema Motlanthe, Deputy President of South Africa.
Good evening, and thank you, Program Director. His Excellency, President of the Federal Republic of Austria, Heinz Fischer and Mrs. Fischer, Conference President Mr. Julio Montaño, Executive Director of UNAIDS Mr. Michel Sidibe and Mrs. Sidibe, Honorable Ministers and Deputy Ministers here present, Excellencies, Ambassadors here present, distinguished delegates, on behalf of the people of South Africa, I thank the organizers of this 18th International AIDS Conference for inviting me to this important gathering. I also wish to express a sincere appreciation to the government and people of Austria for hosting this magnanimous event in this cultural hub and beautiful city of Vienna, which offers an abundance of history and inspiration. I thank our host for the hospitality given to our delegation since our arrival here yesterday. A week ago, an audience of over 1 billion people witnessed the dramatic conclusion to the FIFA World Cup. I'm sure all would agree that in the main, this World Cup provided pulsating excitement and memorable moments that will live on in football history. On behalf of the people of South Africa, and indeed the African continent, I wish to express our gratitude to all the 31 countries represented by their teams in the FIFA World Cup finals. I want to believe this sporting tournament has provided all of us with lessons we can apply in our collective approach to deal with the HIV and AIDS pandemic. One of those lessons is the importance of teamwork, even in the battle against HIV and AIDS. Another lesson is the setting of targets, milestones, roles, and responsibilities in order to achieve those goals. Support from local and international stakeholders has also proven to be priceless in supplementing our efforts. The FIFA World Cup has emphasized the lasting importance of interdependence and cooperation with all stakeholders, domestic and international. Ladies and gentlemen, the timeliness of our participation at this conference is important since we are here to learn, share experience, and compare notes in response to the common challenge. Our objectives and messages have been consistent. Firstly, our government is unambiguous regarding the importance and efficacy of antiretroviral treatment. We are taking all steps to ensure the availability and accessibility of treatment for the needy. Working with our social partners, we have striven to ensure that our response to the pandemic is evidence-based, properly resourced, and effective. Allow me to share with you how South Africa is organizing that wider response. Our medium-term strategic framework builds upon the successes of the first 15 years of our democracy and draws from the lessons identified in the government's 15-year review and issues that arose in our scenario planning process. The scenario planning process identified a number of macro-social dynamics and trends that could present themselves in the long term. It posited that a number of new opportunities as well as some serious new risks could arise in the context of possible scenarios. This scenario planning process resonates with a similar project conducted by the UNAIDS titled AIDS in Africa, 3 Scenarios to 2025. The UNAIDS document juxtaposes some of the issues raised in our own scenarios against the challenges posed by responding to the combined pandemics of HIV and AIDS and tuberculosis. The scenarios throw into sharp perspective the tough choices and difficult decisions governments face in identifying priorities and tackling the challenges of poverty and underdevelopment in a background of unprecedented demand on health systems. The recent message emanating from the Council of the Champions for HIV-Free Generation, chaired by former President Festus Mogae of Botswana, who's present here this evening, is meant to draw attention to the following: to share experiences and encourage leadership to renew and revitalize the response to the HIV pandemic, highlight prevention of HIV as priority number 1, and endorse a policy on medical male circumcision and infant circumcision as a matter of urgency. In South Africa, and indeed in most countries in Africa, the champions have initiated a discourse on the role of traditional leaders in educating communities about responsible sexual behavior. We are acting on the belief that every instrument available in society must be used to address the HIV and AIDS pandemic. In our country, we have deliberately embarked on a substantial HIV testing and counseling campaign. The aim is to allow the majority of our population to know their HIV status and thereafter act accordingly, and where necessary, to access the expanded treatment and support services that are provided. In addition to testing for HIV, people will also be able to receive other essential services, such as screening for, among others, tuberculosis, blood pressure, sugar diabetes, and cholesterol levels. In effect, these diseases require a coordinated response. Working with the South African National AIDS Council, which includes, amongst others, social partners, people living with HIV and AIDS, traditional leaders, performing artists, medical practitioners, researchers and scientists, women, children and youth, we are all working in unison under the theme, I am responsible, we are responsible, South Africa is taking responsibility. Program Director, over the past few years, we have made progress in many key aspects of our collective national response. The prevention of mother-to-child transmission program has seen dramatic improvement. Antiretroviral treatment is provided to well over 80% of diagnosed mothers, and in some of our priority districts, we are succeeding to reduce mother-to-child transmission to below 6%. Therefore, we continue to make the investments necessary and are working hard to ensure that they are proportionate to the response that is required even in the face of declining revenues. The Global AIDS reports show how much this investment has made in realizing the right to health. We cannot let up now and allow recession to take precedence over the right to health and the principles enshrined in the Universal Declaration of Human Rights. Dear delegates, we must also strengthen our collective response by ensuring that aid for AIDS does not result in the creation of parallel policy, parallel governance, and procurement systems in the recipient countries. Rather, we should allow for country-led interventions that strengthen capacity in the respective countries. We need renewed commitment for consistent, sustained, and predictable financing mechanisms. I would argue that now is not the time to disinvest in health. We are pleased, therefore, that the Global Fund has invested close to $10.5 trillion into the response thus far. We must all stay on course. Most importantly, we need to be drawing lessons from responses to other diseases. One key lesson is that our response needs to be united, coordinated, and comprehensive. The UNAIDS 3.1's principle should remain in force, and I would also argue that a broader development framework that brings together the MDGs, the Universal Access Framework, the Angus Report, and all other pertinent national reports is the obvious outcome to make this harmonization effective. The creation of a single unified framework that enables a broad reporting focus on the spectrum of economic, governance, socio-political, and health issues will enable comprehensive planning and budgeting, and will also allow us to apply a holistic and comprehensive analysis to key issues that need our attention. I'm convinced that we are all moving in the right direction, but the next step for us to overcome this pandemic will require harmonization and collaboration across our national responses. We have demonstrated that working together in partnerships across all sectors of society, we can achieve much to ensure all of our people have access to good quality health care. In conclusion, on behalf of the people and the government of South Africa, I reiterate South Africa's and indeed Africa's determination to realize an HIV and AIDS-free generation. 10 years ago, at the 13th International AIDS Conference in Durban, our former President Nelson Mandela urged us to always act in solidarity with others. And he said, I quote, "We want to move away from rhetoric to practical action. We need African resolve to fight this war. Partnership with the international community is vital. A constant theme in all our messages has been that in this interdependent and globalized world, we have indeed again become the keepers of our brother and sister. That cannot be more graphically the case than in the common fight against HIV and AIDS." And I close quote, and I thank you very much for your attention.
His Excellency, Dr. Heinz Fischer, President of Austria.
Honorable Vice South Africa, Excellencies, distinguished delegates, ladies and gentlemen. Our opening meeting for the 18th International AIDS Conference is coming to its end now. It was a very, very remarkable opening meeting, in my opinion. Every speaker, and there were quite a number of speakers, was full of engagement, full of determination, presenting facts and figures and arguments, and portraying a picture of a problem with a worldwide huge dimension. And I really, for a few remarks, will put aside my manuscript, avoiding the danger to repeat one or another fact and idea, and just say that if the further conference tomorrow, day after tomorrow, until the end of the week, is as intensive and inspiring and energetic as this meeting, there's really a chance that those are right who so optimistically said we will be able, united, to reach main goals on this issue. And we do not wait 10 years and not 5 years, as Mrs. Lennox said, but we'll start tomorrow. And we have the very best arguments on our side. And I don't say on your side, I say on our side. And it was impressive how it was described, and I knew it from documents and figures, but now it was presented so lively how big the burden is just and particularly for women, and how children are suffering, and not 1 or 10 or 100, but hundreds of thousands and even more altogether. And it was impressive to listen to the young woman representing the opinion of young people and seeing the combination of self-confidence and suffering and solidarity and optimism. And I can only congratulate you to your approach and to this determination. And it is also impressive to realize and to understand the geographic aspect, that this AIDS and HIV is not distributed in an equal pattern all over our planet, that it are some special regions and parts of our world who are suffering most, and it are those regions where people have much less chances and much less access to the possibilities which exist already today, and which help those in the advanced regions and in the richer parts of our world. And finally, I want to mention that another aspect that gives hope is the progress in science and the progress in the field of medicine, and that every year and maybe even every month new steps are possible for treatment of this terrible illness, and for methods that give not only hope but really change the life of those who are affected and those who are suffering under this illness. So I think this was a very remarkable gathering with contributions from all sides. By the way, even a rather balanced distribution between male and female speakers, different regions, different sciences and approaches. And I thank you very much that you have invited me, given the opportunity to listen and to think about the arguments. And so much thanks was expressed this evening already on the one or the other address, but I want to express also heartfelt thanks to those who have organized this meeting, who have undertaken so much efforts and done so much work. And if one of the speakers has said he hopes that Vienna starts a new period or a new approach, a new progress, I very, very much hope he is right, and then to the next conference in 2 years, if I'm right, in the United States, there will be the possibility to report a lot on positive developments that have starting in the coming days during your meeting. All the best. Thank you very much.
Conference organizers would like to acknowledge the support of the following sponsors: Abbott Virology, Boehringer Ingelheim, Bristol Myers Squibb, Gilead, MSD, Tibotec, Vive Healthcare. Conference organizers would like also to acknowledge the support of the following cooperating governments: the City of Vienna, the Austrian Federal Health Ministry. The organizers would also like to acknowledge the support of the following cooperating institutions: UNAIDS, the Global Fund to Fight AIDS, Tuberculosis and Malaria, World Health Organization, and finally, the conference organizers would like to acknowledge the support of the following donors: the Government of France, ANRS, the Government of Canada, the Government of the United Kingdom, the European Commission, Ford Foundation, the Government of the Netherlands, the Government of Norway, the Bill and Melinda Gates Foundation, Centers for Disease Control, the OPEC Fund for International Development, Positive Action. Thank you for attending the opening session of AIDS 2010.